Good morning, everyone. Welcome to Quality Talks 2018. Now, before we get moving, I want to tell you this year is more interactive than ever before. We, of course, have an app for that, for Quality Talks, that is. You'll find it in both the App Store and on Google Play. Just look up Quality Talks. Be sure to download it to check up on the speakers and to see who else is attending. The app also provides real-time alerts throughout the day, so you will be updated if there are any big changes. Also, remember our hashtag, and we want to hear from you, is QT2018. We'd like to see you on the big Twitter board here and hear what you're thinking about the Quality Talks. We have an amazing lineup for you today. We, of course, have the talks. First up is Ezekiel Emanuel. You'll recognize him as an advocate for improved access and quality for healthcare. He's also the brother of Chicago Mayor Rahm Emanuel and Hollywood agent Ira Emanuel. Achievement appears to be a family affair for the Emanuels. Big family. And we're off with three more speakers following Emanuel. Also, I want to tell you something new on the web stream this year. We're going to take you into the salon sessions that follow each block of talks. We call them speaker hubs, and it's an opportunity to see the up close and personal question and answer sessions that folks here attend. We want you to see a little bit of what you're missing. Oh, and here's something you get that the folks here in the Ronald Reagan building don't get. We've got an extensive interview with NCQA President Peggy O'Kane. The first part of that is coming up after our first round of speakers. You can see the hallway here is empty. That's because folks are in their seats. For now, let's take you to the Quality Talk stage, to my colleague and your MC, Andy Reynolds.
Good morning. That delay is what we call a dramatic pause, so I hope you're primed or inspired. Welcome to Quality Talks. I'm Andy Reynolds with NCQA. On behalf of everyone at our company, thank you for joining us for our different kind of healthcare conference. Here's what's going to happen today. 10 leaders will share novel ideas on how to improve healthcare. Their talks will be short and vivid, and we think you'll remember what you learn long after you leave. The point of Quality Talks is to exchange ideas and to engage with ideas. So, to help you do that, we want to help you get to know the speakers. 3 times today, during breaks, we will invite you to meet the speakers across the hall from this theater in the areas we've marked speaker hubs. We urge you to go to the hubs. The conversations that happen at the hubs will help you get the most out of Quality Talks. The speakers are eager to meet you at the hubs. They want your feedback on their ideas, and they want to continue the conversations that their short talks in this room spark or initiate. If you are among our many Quality Talks alumni returning from previous years, welcome back. You'll notice new features and opportunities for you today, and there are 3 in particular you need to know about. The first is our video recording booth in the hallway on your way to the hubs. Think of the video booth as your Quality Talks stage, or, if you like, your Quality Talks audition area. You can record your own mini Quality Talk, 1 minute, 2 minutes of your ideas for improving healthcare. We might use your clip on the NCQA blog, or maybe your video will be the winning audition tape that earns you an invitation to speak from this stage at the next Quality Talks. Staff at the booth can help you get started. You can record as many takes as you like, on as many topics as you like. The booth is a fun and convenient way for you to capture and spread your ideas. The second thing to know about today's program is the Quality Talks app. We urge you to download and use the app for this event. You can see things and do things and learn things from the app that you can't get anywhere else. And the app is the best way to learn about and connect with other people at Quality Talks. When you use the app, you're automatically a player. And that's because the app itself is a kind of game. A leaderboard inside the app shows who here is making the best or the most use of the technology. And if you're at the top of that list, at the end of the day, you win a prize, a gift, actually, from one of our speakers. The third change or opportunity to know about, the Quality Talks reception. We have expanded the reception at the end of the day. You are all invited, and you do not need drink tickets. So, stay for a while. Get to know the almost 500, maybe more than 500 quality advocates who are sitting all around you. I'll be back to tell you about each speaker. First, I'd like to introduce someone who made it possible for us all to be here. She founded NCQA in 1990 as a one-person operation working out of borrowed office space. Today, NCQA is more than 300 people who, along with many of you, have helped make continuous improvement part of the fabric of healthcare. Please welcome NCQA's founder and president, Peggy O'Kane.
Good morning. This is such a high point for me, this meeting. Once again, I think Andy and his wonderful team have picked such amazing and inspiring speakers. And in the world of healthcare, and particularly today, we all need to be inspired. It's a heavy lift to improve healthcare. Anybody disagree? So let me this is the kind of outline of what I'm going to talk about, which is kind of like where are we on the journey of healthcare accountability and quality improvement? Because what we launched 28 years ago is a journey, and we have to keep checking where we are and what needs to happen next. So I think this is kind of my ideas about really what needs to come together, and it's no small challenge. But I have a particular personal spin that I'm going to put on this today, because 2 weeks ago I had my first surgery ever, which was a cataract replacement, and they messed it up. So I'm looking at you. I can sort of see the back of the room, but it's like somebody rubbed Vaseline over my eye. And so I'm not able to read for any period of time. I went to an opera the other day, and it was excruciating. So I just want to kind of try to weave some of these themes into what happened. And I hope if you pray, please pray for me. And if not, do voodoo dolls or whatever it is. Or whatever, send good thoughts, because I'm not giving up. I think, my goal is to have my vision be where it needs to be, where it was promised to be when I had this surgery. So in order to get to quality that we can trust everywhere, there are some key factors, right? Measurement is a tool in the goal of getting to better health care and better health for everybody, right? And when we started, people said, oh, you can't measure healthcare quality. Well, we really have gotten to measurement, and now I think we're kind of overloaded with measurement, and people are saying, well, what we're measuring doesn't really matter. Now, I would say many of the things we're measuring actually do matter, and a lot of the noise that we have in the system comes from not having gotten our act together about what is being measured at each level of the system, how the data come together. And so the practitioners at the front line are pretty distressed about it. But, and do we need to measure more things than what we're currently measuring? Yes, we do. And I would say particularly patient-reported outcomes, which I'll get to later. But, we have a lot of what I think of as kind of futuristic measurement projects about what really matters to patients and how to capture that. Attribution, I hate the word attribution because it's such a passive word. It's kind of like, well, who are we gonna stick this donkey tail on? Rather than who are my patients and who's kind of sweating about my patients. Really the goal is to have everybody in healthcare really understand what their job is, who they're partnering with, and have the ability to see what's going on. And so that's really important. Attribution after the fact is a pretty feeble, it's kind of more like hitting somebody with a stick after the problem has happened, than really setting up the system in the very organized way that it has to be set up to get the right results. And I'm thanks to my surgeon, I'm now seeing 2 different retinologists. And there's a little bit of the retinologist told me that I had gotten an infection, and the surgeon got mad at the retinologist for telling me that. So, just stuff like that really doesn't help at all. So, people need to have the data they need in order to perform well at the point of care, right? They need to have it. We're not in a gotcha game here. We're not trying to flunk people. What we're trying to do is enable everybody to get 100% on every test, right? We're not there. People are kind of still practicing in the dark, if you will. We need payer-provider data exchange. Okay, so, we can argue, and this is what's part of what I see, now with my own experience, is finger-pointing going on. That really doesn't help the patient, and it doesn't make the care better. So, there are struggles going on all over the country between payers and providers about who's in charge of what. We're in an awkward stage where capabilities at the delivery system level are really different from one place to another, and where payers are often defining quality in different ways from each other. So we need to get beyond that kind of noise in the system. Outcome measures should be part of workflow. And, so if I'm a rheumatologist, I should be able to see what my patient's functional status is today, and I should be able to see the trends when the patient's coming in, right? Because I want to know, how is my patient doing, and not assume they're doing okay unless I hear otherwise. Because people are afraid to talk about it, So all of these things need to come together, and then we can do a great job with American healthcare. And as you've heard me say before in the past, it's not a trade-off between being well-organized and high quality and the cost of care. We need to have accountable entities. We need to be really clear about who's doing what. We need to have good measures, and we need to have clarity about what is happening, and have the patient have the clarity of understanding who they're going to and what they can expect as results, and then actually deliver, not like me, where I was told, oh, don't worry about it. It's like everybody gets these. There's never any problem. Not true. So I'm really excited. We have 10 fantastic speakers. Those of you that have been here before know that the talks are really the invitation to a deeper dialogue back in those hubs. So I look forward to it. I look forward to seeing my many friends that are here today, if I haven't already seen you out there. And let's get started, and let's be inspired. Thank you so much.
Our first speaker is one of the most thoughtful and prolific authorities on both healthcare ethics and healthcare policy. He's also, without a doubt, the best chef ever to speak at Quality Talks. He opened a brunch pop-up here in Washington called Breakfast is on the Table with Zeke. He's also our only speaker who formulated his own chocolate bar, the Zeke Bar. Please welcome Zeke Emanuel.
Thank you for that lovely introduction. It's Monday morning, and probably all of you are nursing some coffee, but I want to talk about wine. I actually don't drink wine, but I'm inspired by wine, and I want to take you back to 1976 and the Challenge of Paris. Some of you may know about this event. A British wine merchant wanted to know whether American California wines were better than French Bordeaux wines, and he set up a blind taste testing in Paris with 11 of the 12 judges, or 10 of the 12 judges being French people. It was blind, and at the end of the tasting, what do you think happened? California wines won. And the French, of course, took this line down, right? No. They said, well, it's too early. The wines will age. The French wines will age better, of course. And they came back, I think, 3 years later. California wines won again. So why, if we're talking about the quality of care, do I mention California wines? Because I think it's a very important metaphor for all of us in healthcare. When we put our minds to it, we Americans put our minds to it, we can achieve greatness, become the best in the world. We all know that our healthcare system today is not the best in the world. It's failing, high cost, failing, inconsistent quality. We can do much better. And the California wine challenge, the challenge of Paris, emphasizes that we have to focus our minds and really change things. So I want to make, I think, 5 points, if the clock will let me do 5 points. And the first point I want to emphasize is that doing better in healthcare is all about behavior change. It's about behavior change on the part of physicians and other healthcare providers, nurse practitioners, the entire provider community. We have to change how we're delivering care. It's also about behavior change on the part of patients. We all know that 40 to 60% of the illnesses and premature mortality in this country are a direct result of our bad behaviors, whether it's smoking, it's food consumption and not the proper food consumption, whether it's the lack of exercise. Changing our behaviors is critical. We also know how difficult it is, right? In about 2 months, we're going to have New Year's Day and all our New Year's resolutions. And in about 3 months, we'll have all those failed New Year's resolutions, right? We all know. It's very hard, right? My New Year's resolution this past year was eat more slowly. And I was noticing last night, total failure, right? Some years I get it, like no added sugar, but this year it was a total failure. So I'm already thinking about what my New Year's resolution is. But we know that behavior change is hard, and it doesn't happen overnight. Just because we make a resolution is not enough. We need to change our environment. So that leads me to point number 1 I'm going to make, which is value-based payment is here. It's going to get bigger, but it takes time to adapt and make the changes relevant to it. Right? When we passed the Affordable Care Act, March 23rd, 2010, there was huge skepticism in both the payer and provider community that we were actually going to get payment change. We were going to go to value-based payment. Physicians and others were going to be incentivized to actually reduce costs, become more efficient, get rid of unnecessary care. I think we're right here in 2018. That skepticism has gone away. It's probably evolving slower than most of us would want, but it is coming. And it's going to come more and more and more. MACRA is going to assure that. BPCI Advanced is going to assure that. We are going to have more value-based payments as we go forward. But if you're in the provider world, you cannot say, well, I've got 1 foot in fee-for-service, 1 foot in value. I don't know what to do, and I can't change all of my practices. I think that is the wrong answer today. It might have been the right answer 3-4 years ago, but it's the wrong answer today. Because one of the things we know from groups that have actually changed is, as I said, you can't do it overnight. To do what Peggy said, to integrate outcomes right into your workflow, all of that stuff takes time, and we know it's on average about 4 or 5 years to transform. You have to start today for 2021, 2022. Because to transform how you're delivering care, to put in all those structures, to get care that is really value-based is something that takes a lot of changes in the processes of care, getting the information to the providers at the right time, actually knowing how to collect that information. It won't happen overnight. We actually have to stop procrastinating and get moving. So that's the first thing. Value-based payment is here, but it will take you 4 years to adapt if you're on the provider side. Second, one of the big moves in healthcare is what I like to call deinstitutionalization of care. Moving people out of the hospital to home. Actually, I think we're going to begin seeing a big movement over the next decade out of the physician office to home. My Two favorite statistics on this are, in 1975, there were 1.33 million hospital beds in the United States. Today, there are less than 850,000, and the population has gone up more than 100%. All right? On a per capita basis, hospital beds have gone down, and hospitalization rate per 1,000 people have gone down. What's gone up? Outpatient visits, now over 1 billion in this country. We are getting rid of institutions as sites of care. We are moving towards the outpatient setting, and I think we're going to begin moving from institutional outpatient setting to more delivery of care at home, right? I've often wondered exactly why is a pregnant woman coming into the OB-GYN every month for that prenatal check? Is there a good reason? Why is the oncology patient coming into a cancer clinic for routine chemotherapy? We're going to be able to shift. It's going to save us money. Patients are going to like it much better, right? And we have to build the infrastructure that's going to make that happen today. It's lower cost, better for patients, patient experience is better, right? We need an infrastructure. We need an infrastructure to deliver that kind of complex care at home. We know we can do it because a lot of places have begun, but we also need an infrastructure that allows us to make sure that that quality in a distributed model is there. And I think that infrastructure, again, takes time to build. Let me talk about 3 interventions on the patient side, which I think are going to be coming up, and they're going to be good for everyone. The at-home care related to palliative care and end-of-life care. This has been an area I've worked on since the mid-1980s, trying to improve end-of-life care in this country, right? The good news is it's gotten way better, right? The bad news is the glass is still half empty. There's a lot of stuff we have to do. Now, for a whole series of reasons, we've been focused on end-of-life care like the last 30 days, that last hospitalization, making sure patients don't have it in the hospital in the intensive care unit because that's not where they want to die. They would rather be at home, surrounded by their loved ones. And truth be told, we've actually done pretty well on that measure. Again, the ability to focus on that. When I started my work, again in the mid-1980s, 70% or so of oncology patients died in the hospital. Today, it's about 20%. That is a seismic shift, right? The bad news is the period before the last month of life, we're still not doing so well. 40% of cancer patients are in the ICU between the last 6 months of their life. Lots of them are still getting chemotherapy, about a third. We have to do better. We have to move that palliative care upstream for all sorts of reasons. And that's going to involve, again, shifting attitudes and then shifting behaviors so that patients get used to getting the care in the house, not calling 911 at the last minute, because that starts a cascade which no one can control to the emergency room, into the ICU. They need trusted relationships. So what have places that have really transformed that done? Well, they've begun palliative care a year out. Is there a predictive model of who's going to die in the next 12 months? Great. No. Is it any harm to someone who's going to experience a lot of side effects and symptoms to start palliative care and get the exact date wrong? Probably not. But we've got to move that palliative care earlier on, get people to get comfortable without high-tech interventions, get comfortable calling a palliative care specialist or hospice, and not accessing the hospital and all of that machinery where they lose control. That, again, is a behavior change on how we deliver care. It's a behavior change on the part of patients. But starting earlier, acknowledging earlier that this patient might die is critically important. And we can't just blame patients. Well, they don't want to accept it, or the family wants hope. Part of that problem is us and the provider community being honest with ourselves and being honest with the patients. Another good big change I think is going to happen over the next decade. Again, we're not totally prepared for, but we all can see it coming now, and we need to develop, is better mental health services. If the opioid epidemic has shown anything, it's first that there is a lot of mental health problems around the country, and that they're being dealt with in the worst possible way: substance abuse. We know that a large proportion of patients with chronic illness have mental health problems. Right? You go to a hospital ward and you screen patients, general medical ward, between 25 and 35% of those patients screen positive for depression or anxiety. Right? We don't have an infrastructure. For 150 years, we have segregated mental health from regular medical care. We've got to bring them together. Now, we know that there are some models, right? Embedded care, you have a mental health provider in with the primary care doctor, or in with the cardiologist, or in with the oncologist, or in with the rheumatoid specialist. That can work. I've recently heard of an orthopedic practice in Austin at the new Dell Medical School, the head of orthopedics, right? They've gotten their joint replacements bundled. So and he's got an incentive to lower the number of joint replacements. What's he done? He's brought people who can provide cognitive behavioral therapy right into practice, because no one comes in and says, I want my hip replaced. They come in and say, I want pain relief. Not all of them are optimal for surgery. Having them manage and deal with the pain without being depressed about it, that's something that he thinks can be very positive. How we integrate that is a challenge. We have models, but I don't think we have anything that is proven to knock our socks off. Embedded providers is one area, but another area is the IT platform, having cognitive therapy on the internet. Lots of patients like it, especially in the new generation, but we certainly need to do it. Let me just remind you, if you actually look at the cost data, right, a fourth largest spend in America, or fifth if you lump all cancers together, right, is on behavioral health. Depression, anxiety, substance abuse, schizophrenia treatment. It's a huge area, and as we all know, it's not been well done, and it's been pretty neglected, and we're living now with the consequences. Going forward, I think it's a major focus, and it'll be much, much better for our patients. And by the way, if you treat that comorbid depression, where it's comorbid with chronic illness, you can bring the cost of treating chronic illness down, sometimes by as much as 50%. Huge savings, huge improvement in the quality of life for patients. Let me end with a not necessarily popular view in 2018. There's been a lot of investment, and you will hear more from subsequent speakers, about virtual medicine or digital medicine or connected health or whatever you want to call it. Wireless interactions. Well, I want to be sober. I think we need to be sober about it. We've been sold a bill of goods on them. So far, all the evidence and randomized studies and rigorous studies using these things, whether they're Fitbits for increasing exercise, or pill capsules for increasing adherence, or wireless scales for reducing weight or monitoring weight, failures. A lot of hype. People tell you all the great things about it, but when you actually subject them to the rigorous studies and try to get that into peer review literature, repeated negative results, negative results, negative results. I believe we will have some areas where it really does work when combined with lots of other interventions. As a standalone, not going to work. And secondly, in my view, having the data is important, but remember, going back to the start, it's about behavior change. And one of the things wireless isn't great at, it's great at giving us our data, right? Last night I looked up, who was the first president who flew in an airplane? I could get that right away, right? Who was it? Teddy Roosevelt. He wasn't president, but just after he was president. But getting us to change, not that good. We're going to need more. So having the information is valuable, but the key challenge for us, to go back to is behavior change on the part of providers and behavior change on the part of patients. And wireless, it's good, but it's not about behavior change. So I hope I've given you some thoughts about where we're going and what our challenges are. But I want to be optimistic because I do think we can solve this problem and we can become a real beacon of lower cost, better patient experience, and higher quality to the world as we proceed. Thank you very much.
Our next speaker calls herself a reluctant entrepreneur. At her heart, she's really a reformer who wants to help her fellow physicians learn to be comfortable having uncomfortable conversations about disease. She helps colleagues learn to what she calls embrace the necessary uncertainty that they encounter when they sit with patients and talk about root causes of illness. Please welcome Toyin Ajayi.
Thank you. So I want to talk today about trust, because I believe that at the heart of ensuring that everyone, including and especially those most vulnerable amongst us, receives the care, the support, and the services that they need to live their healthiest and best lives is trust. Trust is visceral for so many of us. We feel it in our core. It underpins our most intimate relationships, our deepest and bitterest disappointments. It drives our behavior, our choices, our actions. And yet trust has for so long been conspicuously absent in how we design, deliver, measure, and innovate in healthcare. Instead, our systems are characterized by multitudes of insults, by small and large abrasions, by frustrations and failures that erode at the foundations required to develop trusted relationships for patients and communities. We fail to give people voice and agency in the decisions about their own care. And in failing to build trust, we failed to deliver care that is of value to those who need it. And I'm going to ask you for a minute to allow me to describe the experience of the healthcare system through the eyes of a patient whom I'll call Charlene. And I'm going to beg your indulgence a little further to allow me to tell this story in the first person. And as I talk, I want you to imagine that you're Charlene, or that I'm Charlene, because but for a couple of small details and a dose of luck, any one of us could be. So my name is Charlene. I'm 56, I just turned 56. I live in Boston. I'm a mom, I have 2 sons. My eldest recently got married, moved to Virginia. I'm so proud of him. My youngest is named Elijah. He's 13. He has autism. He has ADHD. He struggles to communicate and express himself. We live in kind of a rough neighborhood, and so I have to be extra vigilant for his well-being. But I'm grateful to have a roof over our heads. Most of the time, it's just us. Sometimes, if money's tight, I let my ex, Elijah's father, stay with us. I let him stay on the couch. He chips in for rent and bills. But I try not to too much, because when we were together, he used to get drunk and hit me. He says he's changed, but I'm not so sure. Between taking care of Elijah, protecting him, fighting with the school for every little thing, I don't have a lot of time for anything else. I'm on my way to the emergency room. The pain in my back is so bad I don't know where to turn. I told my therapist about it again. She was worried too. She told me to call my PCP. But the earliest he can see me is 3 weeks from now. When I asked the woman on the phone if there was anything else she could do, she sounded irritated. I don't mean to be a bother, and I'm sure a lot of people complain, but I just know there's something wrong. I hear the doctor telling me that there's something in my spine, and it's spread all over my body, and it's probably cancer. I hear what she's saying, but I have to leave. There's no one to pick Elijah up from the school bus. I don't know how to explain it to these doctors and nurses. They seem so focused on asking me the same questions over and over again. What's my date of birth? How much do I weigh? When did I last see my psychiatrist? What meds am I taking? Am I really taking them? Am I hearing voices? Did I know my diabetes was out of control? For the 1000th time, do I want help quitting smoking? But they're not listening. And so I don't know how to explain to them that I can't stay, I'm just gonna go. Somehow I knew it was gonna end like this. No one in my family has lived much past their 60th birthday. I don't know why I thought it would be different. I didn't expect it to hurt so much, though, or to feel so alone. And I still know there's so many things I need to do to take care of my son, to make sure he's okay after I pass. Charlene died in the fall of 2012 of metastatic breast cancer. She was unique in that she was one of fewer than 35% of African Americans who received hospice service at the end of life. But despite the additional supports that program offered her, she was in severe pain, both physical and emotional. I was the doctor who met her on her first admission up from the emergency room. I was the doctor who received the handoff from the emergency department that described her in clinical terms as a 56-year-old African-American woman with hypertension, uncontrolled diabetes, bipolar disorder, obesity, medication non-compliance, as we tend to call our patients who don't do what we tell them to do, who'd showed up with back pain and tingling in her arms and legs. I saw in her chart that she'd had an abnormal mammogram about 1.5 years prior and that she'd been lost to follow-up, which means that she didn't respond to the phone calls and the certified letter that was sent to her home telling her to come back to the hospital. I reviewed her labs. I saw that her liver and kidney function was out of whack, but it was the CAT scan with masses in her spine, her liver, her lungs, that told the true story. I'll never forget breaking the news to Charlene, her disheveled appearance, her confusion, what appeared to me to be confusion, and then my shock when she yanked the IV out of her arm, put her clothes back on, and left the hospital against medical advice. Charlene returned the following day. She walked back into the inpatient ward, right up to the nurse's station, unceremoniously said she's here, she's ready now to engage in whatever investigations and treatment we recommended. She came back on her own terms, having squared away what she needed to square away at home. But she gave me the gift of a second chance, because this time I could be present, to set aside the computer and listen. And I did. I learned about the primary care appointments that she'd missed because she didn't have childcare or transportation. I discovered that that mammogram follow-up was probably buried in the avalanche of things she was dealing with every single day to survive. I read about her visits to her therapist, complaining of this pain, that knowledge that something was not right. I had empathy for her primary care doctor, who was probably well-meaning, too busy seeing 20 or more patients a day to connect the dots scattered across her multiple electronic records, and to realize the catastrophe that was lurking within this patient's cry for help. And I observed the way her appearance, her way of speaking, her race, her education influenced others, including my own perceptions of her intellect and capability. And I felt her fear for her child, her son Elijah, knowing that this is a society in which Black boys like her son are considered and treated a threat to be attacked rather than a gift to be protected. And when Charlene died, something inside me broke a little bit too. Because at its core, Charlene's story is about trust. At its core, her experience is like that of so many others, most marginalized communities in our society, those individuals whose bodies bear the scars of trust broken again and again in their personal lives, in the fabric of our society that sees them as other and less than. And then, at their time of greatest need, from health systems that fail to listen to what actually matters to them, which do things to people and not in partnership with them, and whose very foundations are designed to achieve goals that are antithetical to building and sustaining trusted relationships. So let's unpack this a little bit. First, all of us here who are in any way involved in the healthcare system have to acknowledge that the values and legacies that underpin our system are steeped in a deep and shameful history of exacting violence on marginalized people, and that it continues today. There are so many examples. I will offer you two. In the 1930s to 1970s, the United States Public Health Service, in partnership with the Tuskegee Institute, conducted research on African American men without their consent, watched the progression of untreated syphilis, despite the fact that there was no treatment for that. In New York, on Staten Island, at the Willow Brick School for children with intellectual disabilities, most of whom had been abandoned there by their families and by the foster care system. Researchers from New York University and Yale in the 1950s to 1970s knowingly fed children live hepatitis virus to observe them and to pit different treatments against them. They watched these children develop nausea, jaundice, liver failure. If that's too far away, what about today? Today, where the cost of insulin in the United States has trebled in a decade. This is unique to any other developed country. This is a drug that was discovered and invented in the 1920s, whose patent was sold for $1. And yet for so many Americans living with diabetes, simply accessing a life-sustaining medication can put their entire life in financial jeopardy. And then we look around at the lists of top-ranked hospitals in the country, world-class institutions that are lauded for the research and medical care that they provide to those who can pay. So many of them abut low-income communities that they have very little regard for. They drive up property prices, they displace populations, all the while signaling explicitly and implicitly that the services they offer are not for the poor, the homeless, or the hungry. That too is a form of violence. This legacy continues, and our patients aren't blind to this. They know. They know this. Every single time a person who is poor, belongs to a racial or ethnic minority, is living with a disability, has a mental illness, identifies as LGBTQ, encounters the healthcare system, they know that they risk being subject to bias, to callousness, to disrespect, and sometimes even to overt violence. It's no surprise that public trust in the US medical profession has declined dramatically over the last half century. In a recent survey, a multi-country survey, low-income American families describe having significant mistrust of physicians and are less satisfied with their medical care than less low-income folks. Less than half of people surveyed in this study believe that physicians can be trusted. So let's acknowledge those foundations. Let's agitate and advocate for a better future. And let's ask ourselves, as we build and design interventions, can we earn back the trust of those whom we seek to serve? And that's the question that I and my colleagues asked when we set out to build our company, Cityblock Health. We asked, what would a trustworthy healthcare system look like? We started with the people. We hired and trained a new workforce of folks we call community health partners. These are individuals hired from the communities we seek to serve. We hire them for empathy, for listening skills, for tenacity, for trustworthiness. They are decidedly and deliberately not clinically licensed. We wanted people who lacked the baggage of the traditional healthcare system, who don't default readily to the lexicon of the patriarchy in healthcare. We surround these folks with a clinical workforce that's skilled, available 24/7, 365, doctors, primary care doctors, advanced practice clinicians, nurses, behavioral health specialists, psychiatrists. Each one has a role to play on the team, but none have primacy over the other. And that in itself is a radical act. We're divesting physicians in our model of power, and we're distributing it across the team, holding the entire care team with the power and the privilege of collectively owning that patient relationship. And then we thought about technology. And so much of what we see in digital technology today is trying to pit technology as a substitute for a trusted human relationship. We don't believe in that. We believe technology should be designed to augment and enable trust. And we built a platform that we call Commons that supports team-based workflows, task management, loop closure, decision support, that makes sure we keep our promises to the folks who we serve, that allows us to streamline referrals, to close the loop when we say we're going to do something, to have full transparency across the team, that we have a bedrock of common understanding so those important and critical details in a person's life don't get lost in the myriad of paperwork that folks have to manage with. And we designed our chart to be transparent and open to our members who we serve, so they can hold us accountable for fully and accurately reflecting their truth in our documentation. And finally, a deep commitment to value-based care. And we hear so much about that. It is so critical because unlike fee-for-service, where success is measured by the number of visits conducted, procedures performed, medications dispensed, for us, success is about long-term outcomes. It's about our members' health and their community's health, not just the units of healthcare that we deliver. And within this, trust is the most important currency. So we're here at NCQA, and so of course I have to talk about measurement, and I want to ask all of you and all of us, because we know that what we measure reflects what we value, and it drives what we do. So we're working to think about measurement that reflects the questions that matter to us. Do our members trust us? Will they keep coming back to us? Will they grant us the privilege of deeply and fully understanding what matters to them? Will they listen when we recommend, suggest, or nudge behavior change, treatments, interventions? Will they turn to us before going to the emergency room? Our success depends in a value-based world on our ability to earn and sustain trust. Therefore, we have to be able to measure it and drive towards it. And as always, I come back to Charlene in everything that I build and do. Would this system that I'm proposing have changed her experience if she had a person to turn to who was embedded within a system that she trusted, a system that understood what mattered to her, that cared about the questions that in between the words that were spoken, that knew and was prepared to deploy someone to knock on her door when she didn't follow up for her mammogram, who could sit in her living room and understand what it was like to live in her shoes, who would share her deep caring for her son and for the better future that we all want to see. And what would it mean to scale this approach across all of our communities, to build a healthcare system that is deserving of trust, to ensure that everyone, including and especially the most marginalized amongst us, receives healthcare delivered by individuals and systems that have earned and continue to earn their right to trust. Thank you.
In the 1990s, our next speaker co-wrote a punk rock song that became a hit in Asia. Then, as a young pediatrician in the early 2000s, he authored a book that the Wall Street Journal called one of the best health books of the year. Recently, he has run some of the most ambitious quality initiatives in both government and industry. Here to discuss what he has learned, please welcome Darshak Sanghavi.
For years, my family and I loved watching American Idol together. We voted, we cheered for our favorites, and yet something bothered me about that show. Why was it, whoops, can we just go back one? Why was it that, we went through this huge process, tens of millions of people voted. You would think that if we were gonna identify the best pop star, we'd be really good at it as a country. So every now and then you got a multi-platinum recording artist, like Kelly Clarkson or Carrie Underwood, but more often than not, you had individuals like Taylor Hicks on the right, who got immediately dropped by his record label, Arista, shortly afterwards. It wasn't only American Idol. Come to think of it, how come when people went on The Bachelor, they didn't come up with stable and loving marriages afterwards? Or the winners of The Apprentice don't run Fortune 500 companies today. Buried in this reality TV paradox is a very important lesson about healthcare today and how we can make it better. And that lesson is simply this. In reality TV, the seeming goal is to identify the most talented recording artist or the most compatible couple. Think about, then, what we do the same thing in healthcare. The goal is, for example, when a child comes into a pediatric clinic, first grader with ADHD, you want to help that boy grow into a well-adjusted adult. Here's the issue. In reality TV, even though the stated goal is finding the most compatible couple or the best recording artist, the thing that we actually incentivize is totally different. It's viewers, it's ad dollars. In a very similar manner, when we think about that first grader who comes into clinic, what's the thing that we actually measure and reward? For example, what do we use for looking at clinical trials? It could be the result of a symptom checklist. And here's the problem. Is there a relationship between what it is we incentivize and reward and the thing that we really think we really want? And we see this over and over again. Let's talk about heart attacks, the leading cause of death and disability in the United States today. Does the middle-aged man avoid a heart attack after a few decades? That's what we want to know. What is it that we measure? I'll come back to this. We look at cholesterol. We look at blood pressure. We incentivize improvements in those areas. Does a healthy woman avoid death from breast cancer? Think about the thing we strongly measure and spend so much time incentivizing, the uptake and use of screening mammography. Or does the perimenopausal senior remain free of a hip fracture as she grows older? That's what we care about, but what we might focus on is the performance of screening scans for bone density. Do those things actually correlate? Well, the reality TV paradox happens when the relation to the actual outcome, to what you're measuring, may not really be strong. After all, does impressing Donald Trump in a boardroom really mean you know how to run a company? Think about that in the context of our question about mammography. Researchers from the Centers for Disease Control and Dartmouth Institute have clearly demonstrated that the rates of metastatic breast cancer have remained essentially unchanged for decades. And in fact, the improvements in potential mortality may be attributed not towards screening mammography, but the actual treatment and the appropriate identification of individuals and the connection with the right chemotherapy protocols. We don't measure those. Isn't that a problem? That's the reality TV paradox. What if the intervention improves the surrogate outcome but has other bad side effects? And here's where The Bachelor comes in handy. Doesn't going on nonstop dates in Fiji and other exotic locales just set you up for the inevitable romantic disappointment of fighting over the toaster? Similarly, if you think about it, the surrogate endpoint of cholesterol, look at torsatrapib or clofibrate, both drugs that powerfully reduced the levels of cholesterol, but actually led to an increase in the number of heart attacks and ended up being withdrawn from the market. These are the things we have to be exquisitely attuned to as we think about improving quality, improving health broadly. So what's a way forward? What's a way through the reality TV paradox in ways that actually improve health? The example I'd like to talk about is preventive cardiology. Again, we want to spend our time on big problems, and heart disease kills more Americans than any other preventable disease. The real goal of preventable cardiology is to prevent heart attack and stroke and ultimately improve high-quality survival. What do we actually incentivize? One-size-fits-all algorithms for screening for cholesterol. In fact, years ago, there was even a movement among the American Academy of Pediatrics to start doing cholesterol screens in toddlers. The AAP thankfully pulled that guideline back. The same can be said for blood pressure targets. There are almost very little discretion related to that. So how could we actually solve this paradox? Move away from simply incentivizing one-size-fits-all algorithms for everybody. The way I thought about solving this problem, and I'm going to talk about a project that we created a few years ago at the Innovation Center at CMS. So the problem is, how do we change something in the future? And the solution we had was to use predicted risk. As many of you may know, if you're over the age of 40 and you see a primary care doctor, the American Heart Association today recommends that you should have your 10-year risk of heart attack or stroke calculated. If you don't know your risk and you're over the age of 40, you are not being exposed to evidence-based care for preventive cardiology. This has been known for many years. So the concept was very simple. Wasn't that a wonderful way to incentivize reductions and identify the highest risk people, engage in shared decision-making? Maybe cholesterol is where you want to focus. Maybe stopping smoking. Perhaps an aspirin is right for you, or perhaps focusing mostly on blood pressure control. So what we did was created and built on the known guidelines, so we calculated a 10-year risk for all individuals. Simply put, if you pass a certain threshold, then you can talk to your doctor about what it is you want to do to lower that. Let's say your risk of heart attack or stroke is high, over 30%. You might really want to focus on making sure that blood pressure reduction is what you focus on, or cholesterol reduction. And by modeling out the impact in the office, the tools there will tell you what to focus on. How do we then make this happen at the office level? Again, very simple. One of the key things with the reality TV paradox is that the reason people watch reality TV is that it's simple. It's easy, you can understand this. Therefore, the interventions we put out there have to be simple. And here's how this one worked. This is what's called the Million Hearts Cardiovascular Risk Reduction Model. It is today the largest randomized trial for paying for prevention ever conducted in the United States, involving 3.3 million Medicare beneficiaries that are randomized at approximately, we initially sought to enroll 720 practices nationwide. Physicians there would risk stratify their patients. You get averaged across your entire panel, and then if you lower that risk across your panel, you get paid. If this was done at the average practice level, that would lead to several, just over $10,000 per physician per year simply to engage in these tools. It's ongoing now, we'll see if it works. But that's one of the key principles, is to test things and potentially think about using these creative strategies to solve this reality TV paradox. We don't always get it right. Let's talk about another major problem, which is diabetes. For those of you familiar with the literature here, the Diabetes Prevention Program was a lifestyle program that was published in the New England Journal of Medicine in the early 2000s. This is a randomized trial performed by the CDC. And some of you have seen this curve. See that the lifestyle intervention, which was just a few weeks, had a durable and long-standing impact on the risk of developing diabetes long-term. Imagine if this was a drug. This would have been approved right away. But because it was a lifestyle intervention, it was not paid for. We tested this at CMS at the federal level and showed that, in fact, the payment model worked. It actually incentivized the diabetes prevention program in a community-based setting. We did this with a bunch of YMCAs. It was wonderful. And that endpoint we chose, the risk of progression to diabetes, was the right one. But we didn't do it exactly right. The week before this was going to be certified for national expansion, I got a call from some of the actuaries at CMS. They said, "Love this program, we have a problem. Turns out that if you prevent diabetes, you live longer." You can see where I'm going with this. If you live longer, you cost more, and therefore we cannot certify this for national expansion. So that's a tough problem. We chose the wrong endpoint. We chose progression of diabetes, not whether you live, thinking that was fairly obvious. So what did we do at that point? How did we solve the mother of all reality TV paradoxes? I contacted my colleague, at the time his name was Patrick Conway, ran CMMI. We said, you know what, there has to be a way around this. Why don't we just write a couple of paragraphs and try to change the rules from the get-go? So we wrote a couple of paragraphs, sent it to the general counsel. We must have caught him on a good day and got this through. Here's the solution. If you can read this. This was a 2-paragraph memo released along with the national certification of the DPP for expansion. The DPP is now nationally expanded in fee-for-service Medicare, as many of you are aware. The Centers for Medicare and Medicaid Services have made a determination that the costs associated with expected improvements in longevity are not appropriate for consideration in the evaluation of net program spending. Yeah. This was our argument. It's just un-American. This led to a variety of other ways of thinking more broadly about incentivizing improvements in health to get at this paradox. We thought about securitizing public health. What about buying public health outcomes at scale through, for example, pay-for-success models? This is one of the ideas that's still been going through clearance. In fact, with cigarette smoking, some of you may be aware, again, the thing we care about is not do you counsel patients in the hospital to stop smoking. I know I'm a clinician, we just check off that box. The issue was that that measure actually even topped out. You know, it wasn't even part of the IQR, the hospital improvement system. What we did was we added a new measure. This is just about 2 years ago, where hospitals will be held accountable for the rate of smoking in the county where they're located, calculated by the Behavioral Risk Factor Surveillance Survey. Imagine that. You're actually held accountable for the smoking prevalence where your hospital is located, and all the hospitals there get the same score, so you have to cooperate. Think about what that does for your community benefit spending and how you think meaningfully about actually reducing cigarette smoking prevalence in your area. What was fascinating was the politics around this. Went to the map at the NQF. They convene this when CMS puts these measures together. The number one supporter of this was cardiac surgeons. Very surprising to me. The number one opposition came from children's hospitals. I'm just going to let that sit out there to explain that at its heart, solving the reality TV paradox is not only about getting the science right and the incentives right. You've got to get the politics right. And that is a very important area for us all to focus on, that this is just as much about winning hearts as it is about winning minds. I'm going to give a final example, which is the opioid crisis. Some of you may be familiar with this line. The rate of opioid death has risen dramatically. It is now the leading cause of death from people under the age of 50 in the United States. How do we solve this? How do we get those incentives right? What is it we measure? I'm going to hopefully just take a little bit of a detour for a couple minutes to give how we think about this problem, how I think about it now. This is work we've been doing at OptumLabs and at United Health Group over the past year. We've not been working on basketball, but just bear with me for a second. Take a look at this win-loss record. This is from a real NBA team over the past couple years. I just want you to, in your head, say, what on earth is going on here? Got it? This is the departure and then the re-entry of LeBron James to the Cleveland Cavaliers. Took his talents to South Beach and then came back. One man was the difference between success and failure for the Cavaliers. That's how we've thought about healthcare for too long. Talked about reality TV. Sports is the ultimate reality TV. What can we learn from this? That one measure is going to fix everything. I submit there is a better example, which is these are screenshots from ESPN from the Olympics in Rio, where the U.S. women's team was heavily favored to beat the Swedes. Look at that. Shots on goal, expected goals, possession time, completed passes. And they lost. Why? The nature of soccer is different than basketball. Soccer is about the million things that have to go right. Defending the ball, kicking it up, getting it all the way through. It is about weak linkages. I submit that the opioid crisis, like many healthcare crises, is about weak linkages. You are only as good as your weakest link, and there are a lot of them. And so if we're going to solve the opioid crisis over the past year, my group, along with support from numerous national experts, CDC, SAMHSA, experts at Mayo Clinic, Harvard, University of California, and others, worked together in an expedited time frame in 4 to 5 months and created 29 measures, fully programmed, benchmarked, and standardized, and they're claims-based, and actually, at our enterprise, they're issued on a quarterly basis across all lines of business. These fall into those 4 categories. This is how we're playing soccer with the opioid crisis. We are tracking each of those, and then we're seeing what works and what doesn't work. And I'm going to close with an example of how we're trying to bring that thinking in with the focus on that meaningful outcome. This is a map of an initial prescription. In other words, people who are not on chronic opioids, when their physician writes them a prescription, is that prescription being written in compliance with the 2016 CDC guidelines? MME, Duration, co-prescription benzos. Many of you are familiar with those. Look at that. It is normally distributed. It's amazing. And those are meaningful differences. Though it's 20% compliance up to 100% compliance. On average, half of the prescriptions, and this was 2017, are written out of compliance with CDC guidelines. That is bad because every day of additional prescription increases your risk of long-term opioid use by a full percentage point. How do you address this? And look at that geographic disparity. Counties that are performing well are next to ones that don't. And so we rolled out a national program in the summer of 2017 called Hard Edits. At the point of service, if your physician wrote a prescription out of compliance, and remember, this is for your first prescription. If you're on chronic opioids, have chronic pain, this did not apply to you. It's only for new users. That, at the point of sale, will be hard edited down to a prescription that's compliant. Within 3 weeks, we saw an increase from 55% compliance to over 95% compliance nationwide. And then we saw a resultant significant reduction in the incidence of new chronic opioid users. Sounds like a great story. There's a caution, just as there is in any reality TV paradox, is that we have continued to see an increase in overdoses throughout our lines of business as the country has broadly. And what that says to us is that while we're on the right track and we think we're doing the right thing, that is not going to get us where we need to be, which is now going to require a substantial focus on the treatment of opioid use disorder, and we've redoubled efforts in that area. In closing, what I'd like to say is that the reality TV paradox is one that plagues us all as we think about what it is we incentivize and what it is we really care about. What I'd encourage us all to do is, as we move forward, at least do it deliberately, and please check frequently to see if what you're doing works. Thank you.
Our next speaker is an Oklahoma native and a self-described hockey mom who uses data and feedback to create health systems that learn. The health system that she ran in Utah was #1 in the country for quality and safety. Recently, she joined part of the Google family of companies to explore how technology can help doctors know and deliver what their patients need. Please welcome Vivian Lee.
Thank you, Andy. Well, good morning, everyone. I'd like to tell you a story that starts in the summer of 2011. It was a hot and muggy morning. I got myself into a cab to JFK, got onto a flight to Salt Lake City, clear, crisp blue skies, and my family and I were just about to embark on an adventure there. I was just about to become the new CEO of the health system, the dean of the medical school, and the senior vice president of health sciences at the University of Utah. And at that time, there was a lot of national debate about the Affordable Care Act, the constitutionality challenges that were moving through the courts. But for most of us, we were really attuned to the headlines that said, the train has left the station. The value train had left the station. Actually, the value train had only left some stations. And in Utah, we only really got a sense of it the following year when a couple of things happened. First, the Utah Medicaid office announced to us that as of January 1, 2013, all of the payments for Medicaid were going to become capitated, meaning we would get a fixed amount of money per member per month, and of course, if we overspent that to keep our patients healthy, that would be our loss. The second thing that happened was that CMS announced that they were looking for sites to participate in the bundled payment pilot project, and did we want to participate? Now, as a brand new CEO of a $3.5 billion health system, you might imagine that the thought of taking financial risk for all of our patients and their costs of care was terrifying to me, terrifying. And then when my team came in to try to explain the bundle payment pilot project, it just made it worse. Because they said, well, CMS is going to come in and look at our historical payments for, let's say, a total joint replacement, and then they're going to take 2% off of that, and that's going to be the new baseline. So I thought, oh, so appealing. And then they said, if we manage to reduce the cost of care even more, let's say $1,000 less for a total joint replacement, we get to share in those savings. Okay. The first thought that came to my mind when I heard that was, if we hit it lucky and we actually manage to reduce the cost of care, the first person to come into my door is going to be the chair of orthopedic surgery, saying, oh, thank you very much, that's my $1,000. Followed by the chair of anesthesiology, the chair of physical medicine and rehab, the head of the operating room, the step-down unit. You sort of get that picture? It sort of brought a whole new definition, a whole new meaning to that idea of two-sided risk. I sort of felt like we were damned if we did and damned if we didn't. So immediately as I reflected on that, I thought, well, three things have to happen for us to be able to survive, or for me personally to be able to survive in this value-based, risk-based world. The first was that we're going to really have to figure out our costs of care, particularly for things like the bundles, total joint replacements, cabbages, and so on. The second was that we were going to have to really figure out if there were opportunities for us to reduce those costs of care. And then the third would be to figure out how to attribute any cost savings or excesses to the right entities across the institution so that we could collectively be at risk, not just on my head. So that's what we set about to do. We set about trying to work out what the costs of care were for each episode, and together with that, also looking at the overall quality or outcomes measurements for each of those episodes of care, for each physician and each patient interaction. And we discovered that we weren't the only system in the country. It turned out to be that most of the nation really had no idea about the cost of care at that level. And when I say cost of care, I'm really referring to the cost of us running the business, not what we were billing or charging, but what it really cost us to run the hospital. And once we started looking at those costs, it was really phenomenal. The impact was amazing. I, as a radiologist, I had no idea how much it cost us to, say, keep a patient in the MRI scanner for an extra 5 minutes, or for a surgeon to stay in the operating room an extra 10 or 15 minutes, much less what the cost of, say, that hip implant was, or the cost of anticoagulation therapy, for example. We really had no idea. And once we started looking at the data, the impact was transformative, because you may know, many of you may be physicians yourselves, that physicians are quite a curious lot. We were curious about the information, and then we're also a rather competitive group of people. Those of you who aren't physicians may remember us back in the college days as those pre-meds. That was us. So once we started putting out that data, though, it turns out what really drove our physicians on the competition side was less the cost and more really about the quality, because most of us really wanted to be thought of as delivering the best outcomes for our patients. And as we started to look at both the measurement of cost and quality, it turns out that our physicians were not particularly satisfied with the quality measures that were being defined by our payers. And so they asked us, could we offer a few of our own perspectives on how to measure quality and how to define value. And we accepted that. In fact, we welcomed that, as long as the parameters were evidence-based and justified by the literature. And that really gave us a lot more buy-in in this journey to value, because we agreed that we needed to listen not only to the payers' voices, but also to the physicians and clinicians and frontline voices. As the organization started to move forward, we did see tremendous buy-in. We saw continued increase in our quality metrics. We saw cost reductions. Many of those actually did contribute to our bottom line, so we saw an increase in our operating margin, almost twofold. We also saw increased employee engagement and a much lower rate of physician burnout than nationally. That said, as our organization started to think a lot more about value and who should be defining value, something became so obvious to all of us, which is that we were really missing the most important voice in the discussion about value, which was the patient's voice. Now, at the University of Utah, we had done a lot of work in patient satisfaction. And in fact, we had really prided ourselves on being among the first to really engage patients with surveys. And we were the first in the country in 2012 to post our patient satisfaction scores online with the familiar yellow stars. So we did that in December of 2012 and included all the patient comments. So it was sort of a natural next step to move from patient satisfaction questions to really asking patients about their actual outcomes. About maybe 4 or 5 years ago, we started collecting patient-reported outcomes, asking patients either on their phone, on their tablets, on their desktops, or in the waiting room of our clinics to answer questions about their physical function, about their psychological well-being, including screening for depression, and also their social well-being, how engaged they were in their communities, whether they felt isolated or lonely. And that information has really fed into our overall measurement of quality and our overall measurement of value that we're delivering in the healthcare system. Now, my thinking about the value question has really evolved even more, because I thought to myself, well, this is a really great step. It's great to ask patients how they're actually doing when they come and see us in the clinics, or when they come see us, or when they're discharged, let's say, from the hospital. But wouldn't it be even better? Wouldn't it be even better, first of all, if we just avoided hospitalizations altogether? Wouldn't it be even better if we not only asked them how they were feeling, but if we had a little bit more data and insight in terms of their own biology and their own physiology? And wouldn't it be even better if we got data not just when they were in the clinics or in the hospital, but the 99.99% of their lives when they're not in our healthcare system, when they're at home, when they're with their families, when they're at work? And wouldn't it be even better if health wasn't just about the delivery of care that we provided as a system, but if it were really about the co-production of health, the co-production between our patients and our delivery systems to produce health? And I've had the opportunity to think a lot more about that recently, about after a year sabbatical, when I've been working on a book on healthcare reform. Stay tuned. I joined 5 months ago a company called Verily, and I feel very privileged to have done that. It's in the technology sector, as you heard. It is part of the Alphabet family. It is the healthcare and life sciences part of the Google family of businesses. And there I've really come to appreciate what can happen when you can bring together technology with our healthcare delivery system to really think about what matters to patients. And probably the best way to explain that is to tell the story of Stephen from Marietta, Georgia. Stephen's been very open about his health and his healthcare. You can read about him actually online. Stephen had been experiencing, he had been categorized as being pre-diabetic for years. And then about a year ago, he started feeling really bad one day with some nausea and vomiting and some dizziness. He went to the emergency room. His blood sugar was 440, and he was diagnosed with type 2 diabetes. And for the ensuing months, he tried pricking his finger all the time. He was very good. He was really trying, took his medications, and he still just didn't feel like he could keep his blood glucoses under control. So on the advice of his physician, he enrolled in a program that was sponsored by his insurer, Blue Cross Blue Shield of Georgia. And that program was a virtual diabetes clinic offered by Onduo, which is a joint venture between Sanofi and Verily, the company that I work for. So when he participated in that, the first thing that he got was this device, the pink device here to the right. It's a continuous glucose monitor. It's a little smaller than a quarter. And within it is this chip that has a blood glucose sensor, as well as the world's smallest Bluetooth transmitter. And he puts this device on his abdomen, and it has a small wire that goes just under the skin and measures his blood glucose, or estimates his blood glucose continuously, and then transmits it to the app. So no more finger sticks for him. He has 24/7 insights into his blood glucose. And then on the app, which was developed by Onduo, the device was developed by Dexcom with Verily. But on this app, a few things happen. So first of all, you know that the most important factor to your managing your diabetes is really what you eat. And so what Stephen does is he takes pictures of his meals and of his snacks. And using some Google machine learning, computer vision magic, it's magic to me, it recognizes his meals, and it actually estimates the nutritional value of that. And as he's looking at his meals, he can also track there, right below that, his blood glucose. The blue bar, the light blue bar, is where we're hoping his sugars will remain. And so he can see that that muffin type thing probably wasn't the best. You could see his sugar sort of spiked after that. He can also track his exercise on the same app, and he can share all this information with a coach, with a health coach who's available to him 24/7, and that coach can offer some useful insights that he himself might not make. So for example, after he had done this for a few weeks, they realized together that it was high fructose corn syrup that somehow was a real trigger for Stephen. And as long as he avoided that, he was really able to manage his blood sugars. And so for Stephen, this story, I think, brings together what happens when you have the technology with the sensors, you have an app that has some engagement and really can kind of help you get insights into your own body in a way that you've never had before, together with some healthcare expertise to figure out on the patient's terms what matters and how to kind of get him to where he would like to be. Now, with diabetes, we know about blood sugar. We understand more or less the physiology, although we've actually, as you can imagine, gained a lot of new insights that we never imagined before with this, with the thousands of patients that are in it. But there are many other diseases that we don't have such a good sensor and such a good marker. So I just want to leave you with a little bit of a teaser of what might be possible and tell you about this project that was started, or was maybe formulated about a decade ago by Rob Califf, who many of you may know is a leading cardiologist and clinical trialist and a former FDA commissioner, together with Andy Conrad, who's the CEO of Verily. And they recruited a woman, Dr. Jess Mega, from the Brigham and Women's, to run this project called Project Baseline. And their hypothesis was that most of us in healthcare, we're trying to figure out how people transition from health to disease. And for the most part, the information that we really need to predict that transition is probably not being collected by us in the traditional healthcare system now, because it's probably more to do with the food we eat, the exercise, the environment, the air we breathe, how well we sleep, obviously to do with our omics, our genomics, our proteomics, and even with our microbiome, all the bacteria that kind of cohabit our bodies. So they set out to collect all of that information. It's about 6 terabytes per patient, thousands of individuals over many years, in order for us to gain that insight and be able to figure out what are the sensors that we need to develop, what are the apps and technologies we need to help so that we can understand ourselves and control our own fates and maintain that health. So for me, this is the ultimate journey in value. It's really all about how do we create the very, very best outcomes and define that value in terms of the patient and what matters to us. And then, of course, prevention is the lowest possible cost. So the journey to value, in my mind, is really only just beginning. Thank you very much.
Let's eat, and then let's meet those speakers. We will welcome you to help yourself to lunch now, and then go to hubs in that order. We're eating first, then the hubs. To know when it's time to move from lunch to the hubs, please listen for chimes. To know when it's time to move from the hubs back to this room, we have a musical reminder.
So this is my bad comeback song.
That's Darius Rucker singing the comeback song, so you get the point. Also, one last thing. Breaks like this are a great time to try the video booth. Some brave pioneers have already given it a shot.
Is the #1 concern.
There are millions of Americans who live with a mental health condition.
One of our biggest challenges is the quality of care that we provide to moms.
I've had some really positive experiences with the healthcare system, but I've also had some negative ones.
There are some ways that we can improve.
Looking for more standardized electronic data, we can see what's really going on.
It'd be great if my health insurance covered my gym membership, something like that.
Do try the video booth, enjoy lunch, and we'll see you here. Thank you.
Wow, what a start to the day. You can see behind me over the next few minutes the folks pouring out of the amphitheater and heading for lunch. That was our first block of speakers, and I'd say it was a pretty good start. As the people here start heading to lunch and then the hubs, do not worry, we have a lot for you. We have our taped interview with Peggy O'Kane. We've arranged several guests to share their insight on what they're learning here, and we have some information to share with you about NCQA and its many programs and research. There's a lot on the agenda, so let's get started with Peggy O'Kane. She's led the charge here at NCQA since the very beginning, nearly 30 years ago, and there's no indication, as you saw there earlier, that she's slowing down. I sat down with her recently to have a talk about NCQA, healthcare quality, and where she thinks we're all headed. Where are we in healthcare? Sort of on the spectrum between technology, 8 minutes, and those intangibles. Are we in a good middle place, or are we?
We're at the brink of a lot of changes in healthcare that I think we can't even imagine, even if we're trying really hard. But technology introduces the opportunity, I think, to have the patient be more engaged in their own care. I mean, I have my Apple Watch that's giving me continuous readings on my heart rate and stuff, and my exercise and so forth. And you can imagine the applications for people that are trying to manage a chronic condition and so forth. There is really a lot that can be done and that we haven't done yet. And I think it's kind of like the journey of measurement, which is you never really know very far out where you're headed. You can only go as far as your headlights. And you discover things as you make changes that are unexpected, and sometimes they're unexpectedly great, and sometimes they're not so great. So you have to be constantly checking your course.
And regenerating in
some ways,
right?
Exactly. I mean, that's what's wonderful about my job.
It's never
the same. It's never the same.
What is your assessment of sort of the system, the health of the system? Be the doctor and give us a diagnosis.
My diagnosis is there are some beginnings of conditions that really need to be attended to if the patient is going to be well. There is too much out-of-pocket cost for the average person these days that gets in the way of their going for wellness visits. Even though wellness visits are covered, preventive visits are covered, it's confusing to people, what does that mean? What's really covered? That's one thing. I think for practitioners, we're in a very awkward stage where they're really struggling with their electronic health records and with the need to document what they do. And I hear these terrible stories about people working hard all day and then having to sit around and input data about what they did all day for another 2 hours, either at home or in the office. That's not a healthy state of affairs. The tender, loving care that we all want from the system, it can't be given by people that are stressed out. We're kind of trying to negotiate our way through this without making everybody really discouraged and burned out.
Because one of the dangers, and you're jumping ahead on me, but one of the dangers in this is that with measurement burden, is that we are looking for certain measurements, other people are looking for other measurements, and then it becomes overwhelming for the...
Yeah, there's a real need for all of us that work on the demand side of quality measurement to get our act together. So we often have different plans with different measures, NCQA with its measures, CMS with its measures, Medicaid, each state with its own measures. That really doesn't add up to anything that's good. It doesn't even improve the quality. Because if you think about, you're a practitioner and you've got like 30 different things that you're trying to manage to, that's not going to happen.
When you say get our act together, you mean get it aligned.
Get ourselves aligned.
Yeah.
We can all agree that there are some things that are really important. And, because what I'm talking about is we may be measuring on the same topic, like diabetes or blood pressure control or something like that, and we may have different thresholds for what's good. That makes no sense. Mm-hmm. We really want to get our requirements aligned and let people focus on the hard work of getting to the best outcomes.
How do things like electronic measures your wearables, the data from your wearables. How do they help in that? Getting us aligned, do they?
Well, yes. I mean,
Outcomes
we're
measures.
embarking on something we're calling our data and measure roadmap. So, HEDIS measures used to come from claims data, and then people had to go and look in medical records for more information. Very, very costly, clumsy. People get the information about how they did too late. So, but now we have electronic health records that are coming along. They're still not very great, but we can all see that soon enough we're going to be able to pull out of those records the information that people need to achieve better results. And so for quality measurement, that hasn't been a possibility. But now, if somebody from a large medical practice, for example, can just push a button and answer, what is your quality measure report for this topic, that takes a lot of burden off everybody. And it also puts the measurement closer to the people that are actually delivering the care. So we're aligning the measures at different levels of the system, and we're allowing for the data to come from different sources. But that has to be standardized so that we can make comparisons.
And NCQA.
This is a big deal.
It is a big deal.
Yeah.
It's the future.
Yes, it is.
And NCQA we're in that space taking a leadership role.
We're really trying to bring the future here fast, because we're in a race with the kind of clumsiness of the current environment.
We have stepped into the opioid battle with measures that sort of track prescriptions. That's what we can do. Why is it important?
That's one thing we can do. That's our first, but
right.
there is a lot more in the opioid space that needs to be done. I think that at the plan level, it's pretty easy for a plan to look at their prescription data and see which patients are getting multiple prescriptions from different doctors. Yeah. Mm-hmm. Also to see which patients are getting put on opioids, high doses of opioids, when they really shouldn't be. Mm-hmm. So the plan can do a lot, and some of the plans already have. There have been some initiatives like in California where the plans have made it their business to kind of really monitor the use and try to prevent this horrible addiction that people are suffering from. I mean, it's the #1 killer in the country right now, which is kind of unbelievable. Mm. And it's killing young people. It's killing people that really weren't sick. A lot. So it's really unnecessary. That's the kind of quality problem that, it makes you really want to stop the things that are causing it.
And you said there are other things we can do. Is there anything in the future coming down the
We're
pipeline
exploring doing a program to evaluate providers of addiction treatment, mm-hmm. which often relates to opioids. So we're not sure yet what our play is going to be, but there's a lot of need for better treatment at the delivery system level. And there's this kind of very good evidence that medication-assisted treatment really works, but we also have providers that are philosophically opposed to that. And the concept of people go from one drug to another drug, but that's really not a good way to look at it. I mean, if people can be sober by having medication assistance and they can live full lives, then what is wrong with that?
Well, that was part one of my interview with Peggy O'Kane. The second part's coming up. Did you know there's a new guide for organizations that help the most vulnerable among us, the elderly and the disabled? You do not want to miss the chance to hear Peggy O'Kane speak about long-term services and support accreditation in the second half of my interview. That's about an hour and a half from now, so it's in the second block, so you'll want to stay around for that. She's really passionate about finding new ways to improve care for vulnerable populations. Again, that's after our next round of Quality Talk speakers. But at first, let's get a look at what's happening right now here at the Ronald Reagan Building. You can see crowds are in the hallway. They're getting lunch, getting ready to head for the hubs, but stopping again for lunch and some networking. You really should try and make it here next time. because it is a great event. It's a good time, and it goes very quickly. Here to talk to me about why they sponsor and what they find in the value of quality talks and the value of quality work is Jessica Kratz. She is with Merck, and she's joining me. First of all, let's talk about why Merck sponsors quality talks. You've done it multiple years. There's a reason.
Yes, this is our 4th year, and quality is very important to us at Merck because it's the cornerstone for improving healthcare, and our products play a very important role there. But if quality is not embedded into the value proposition for the products, then it really doesn't do the patients a very good service. So we feel it's really important to sponsor events such as Quality Talks so that the message of quality gets out and that we can make real change in healthcare.
And there really is, even outside the talks, there really is a lot of discussion among all the people working in this space, sort of sharing ideas at this event, right?
There is, and what I love most about this event is the speakers present in such a different format. It's thought-provoking, it's emotional, it engages you at your core, and it really gets you to think about what can be very meaningful in my day-to-day that I can make a big footprint on U.S. healthcare. And that's what I really love about this conference. It's different than any other conference. Not that the others aren't good conferences, they just have a very different purpose. And other conferences I go to learn more tactical, more practical information. This is more big picture, outside the box. What can we do to really change the game?
And speaking of emotional, our last block today of speakers, we have 2 really great people, Liz Salmi, who is a brain cancer survivor, and Travis Mills, who really isn't in the the healthcare space, except his story is so inspiring, and he has been a patient many, many times for a very long time. And so that will be very emotional. It's the final talk of the day. You have to stay around for that. So let's talk about Merck's work in quality.
Yeah.
What's going on at Merck that you think we should know about?
So my role is really to be a quality consultant for our commercial organization. And when I was hired into the role, I was working more with our marketing organizations for products that were in promotion. The role has significantly evolved, and I spend more time with our pipeline teams. And so I'm working with researchers in our outcomes research as well as clinical research and helping them understand what quality is, why it's important, and how that can be translated into how our products are used. And so we're doing a lot of early thinking around not just a product in terms of safety and efficacy, but also how does it benefit the patient in real world use and in their overall outcomes.
And I know you've worked with some of our researchers on how to make sure folks are taking their medicine,
yes,
right?
And that's actually one of the end goal outcomes, right? Is for the patient to actually take it.
Right.
So, yes.
So tell me your speakers this morning, who'd you really like?
Toyin really touched me. The concept of trust, I think, is so universal, and not just, she really focused on the disadvantaged populations, but I think that is an issue that transcends for every patient at some time in the healthcare system. I'm a nurse, and I've certainly seen that firsthand. I worked in pediatrics, and I would see it in both the children as well as the parents. And coming into the healthcare system is usually something that's not done by choice. It's usually not done proactively, unfortunately. And it can be a very scary time. And if you don't trust those that have so much control over what happens to you, both physically, emotionally, and spiritually, that can be a really scary and horrible place to be. So her talk on getting people to understand that and think about it, that they're not just a patient that I have to enter into the EHR, that is huge, and I really appreciated that.
She did such a good job, too, by putting it in first person, making us really see that person. Jessica Kratz, thank you very much for joining us.
Thank you, Matt.
Thank you for
it's a pleasure.
being at Quality Talks, and certainly thank you to Merck for supporting it for so many years. Enjoy the rest of your Quality Talks. We'll talk to more of the folks here at the Reagan Building coming up, so keep watching with us. But first, long-term care is among the many areas where NCQA works to promote quality. NCQA's accreditation for long-term services and supports, or LTSS, aims to help organizations become more efficient as they manage person-centered care for the most vulnerable patients. Well, we know coordinating care for the seriously ill and the elderly is hard, complex work. So we're constantly looking for ways to improve. To help with that effort, we created the LTSS Best Practices Academy, where healthcare professionals shared strategies for coordinating quality. The Academy wouldn't have been possible without the support of Preferred Population Health Management, led by President Jim Vandagrifft. We sat down with Jim, who describes his passion for helping organizations that care for people in the place they most often choose to live, that is, in their own homes. It was perfect that you covered.
The community-based organizations are the only ones who get paid to keep people at home. And that becomes a big part of why I'm so passionate about this work. Being able to help seniors, those with disabilities, anybody with chronically ill conditions. Population Health Logistics, which is the tool set that allows community-based organizations to be able to capture the data on the clients that they serve so they can kind of see the macro data as to how their population's doing, but then also drill down to individual lives at a granular level and what's impacting them and how to move the dial. So if we take it within any given agency that may have anywhere between 1,000 to 5,000 lives that they're trying to help navigate and manage those issues, I need to know those ones that may be in trouble, and that's where I need to spend my time. And so the technology just helps them better focus in on that and identify quickly who is most at risk and how can we intervene to ensure that they don't end up in the rapids and being fucked by the health system. The LTSS standards, the guidelines that are used, is a part of this, the accreditation process that community-based organizations will go through. Part of it is they've got to be able to conform to certain standards, benchmarked for quality outcomes and measures, and the tool set provides the collection of that appropriate data. It allows them to know how they're performing. If they begin to see that they need to make corrections or modifications, they can do it real time. They don't have to wait 30, 60, 90 days later to see the outcome to realize they did something wrong and they could have made a difference. It gives them that real-time information. So those standards are a part of our platform and built into it because we want to be an integral part in working with the community-based organizations in the delivery and meeting the quality standards that NCQA is known for. Well, of course, NCQA has a phenomenal reputation across the country, both working with managed care organizations or working with health systems. The mere involvement that you're aligned in us being able to be a sponsor to support the launching of the Best Practices Academy for these early adopters. The fact that we're seen in that same light, I say that the reaction from those that we talk to on a regular basis has been absolutely overwhelmingly positive. They see the value in it. They see the value in the continuum as we move the dial away from the traditional fee-for-service and delivery of care, and that doing it, quality is a large impact. So how is it we ensure we're there? With doing work alongside of NCQA, it's like that gold seal.
That was Jim Vandagrifft on the LTSS Best Practices Academy. We're going to move on because we're going to talk about that population. Joining me now is NCQA's very own Erin Giovannetti. I said it right. A senior, it took me like 3 years to get that right. A senior research scientist. Erin researches best practices on a number of fronts. We thought you'd be interested in her work. That includes measuring quality for people with complex needs and person-driven outcomes. And Erin, what I think, and I know you do so much, but what I know about is your work with trying to define goals and helping people set their own goals. Tell me about that.
So a lot of what I try to focus on in quality measurement is how do we really get to those measures that matter? And when I talk to populations that are complex, they have some type of disability or aging or other things that are making their healthcare complex, I ask them, what really matters most to you? What is it that you want to get out of your healthcare in your life? And what we find is that when we talk to people about what matters most, they don't all say the same thing. Some people talk about wanting to play with their grandchildren. Some people talk about wanting to get back into the workforce and be able to work. And when we think about our quality measurement system, which kind of says we're going to measure the same thing across the entire population, that doesn't work when people are very unique and individualized. And so what we've tried to do is think about how can you come up with a measurement system that allows you to actually measure in a statistically valid and reliable way. I mean, I'm measurement scientist, but you're also getting at what people say matters most to them. So helping them to define a goal, what they want to achieve, and then measure whether or not they are achieving it. And our end goal is to be able to say, can we drive healthcare towards a focus on what people are telling them, people are telling their providers matters most to them, and then actually measure how well providers are helping them to achieve that.
It sounds so difficult. How do you make that happen? Because it just seems so difficult to me in the sense that everybody is unique and has their own needs, which is why we want to measure it in the first place, right?
Everybody is unique, but I'll say we have some advantages going for us, which is, first off, when I try this and in some of the research we've done, and we've talked to different types of providers, social workers, nurses, community health workers, physicians, they all say, this is why I got into this field in the first place, is I want to help people, and I want them to tell me what matters, and I want to help them achieve that. And they actually get frustrated sometimes when there's quality measures they're being measured on, and they don't feel like they're actually reflecting what it is they're doing. So in some ways, what we're trying to do is actually align this measurement approach with what we hear providers telling us they want to be doing, they feel like they're already doing. They just we don't have the measures yet to demonstrate that they're doing it well. And on the other side of that, patients want to talk about this stuff. They want to talk about what matters to them. And when we've done this research, what's been most wonderful to me is that there's been a lot of people that have said, that's the first time anyone actually asked me that. I need to think about that. What do I really want? And if I stopped worrying about my hemoglobin A1C and blood pressure and BMI, what is it I'm trying to achieve?
Where am I trying to get?
Yeah.
Physically about me, I don't even know what A1C is, right?
Right.
Your patients, some patients for the most part. So there's a quality effort in here, not just for the patients, it turns out. There's an improving quality for the provider as well, right? They're more satisfied and they're doing the sort of things they want to do.
It's absolutely true. One of the main things we've been trying to do with this is that it can't just be quality measurement for the sake of quality measurement. It has to be valuable information that is making providers feel they're actually able to provide better care because they have this information, and that they're able to actually change the way that their care is being provided, because they're now going to be rewarded for helping that 85-year-old woman be able to play with her grandkids.
Now, I promise you I wouldn't ask you anything you couldn't answer.
Yeah.
So, tell me what you think of the talks. What
The talks are great so far. It's been really great. I think it's always good sometimes to get differing opinions on things, and you see this kind of contrast between different people trying to solve and tackle the same problems.
In different ways,
In
right.
different ways, and I think that's been, it's really great as staff members that we get to go to this, because they really do challenge you to think about quality measurement in a different way of, I hadn't thought about that.
Well, thank you very much, Erin, for joining us.
Thank you.
I knew you'd be good. That's why I asked you. So thank you very much. That's Erin Giovannetti. She's a research scientist right here at NCQA. There is so much more to come for Quality Talks 2018. Our guests here are grabbing lunch, and then they'll head to the more informal question and answer sessions. We call those the speaker hubs. Do not worry, we aren't leaving you out. For the first time ever, we're going to take you to select hubs here at the Reagan Building, so you can get a feel of what it's like to attend Quality Talks in person. When the hubs are settled in, we'll take you there. But in the meantime, we're going to share a throwback to our first Quality Talks. In 2015, Rebecca Onie delivered a quality talk that people still talk about today. What does or does not count as healthcare in this country? Here's Rebecca Onie on the first Quality Talk stage.
Our next speaker, by her own account, has spent 20 years obsessing over how to make healthcare more just and more rational. Today, she'll challenge us on how to reach that vision using tools that we already have. Please welcome Rebecca Onie.
So today I want to talk about what does and does not count as healthcare in this country. For me, the story begins in 1995 with a freshman year internship in the housing unit at Greater Boston Legal Services. I was paired with a righteous, deeply inspired attorney named Jeff Purcell, who thrust me onto the front lines from the very first day. And over the course of 9 months, I had dozens of conversations with low-income families who would come in presenting with housing issues, but there was always an underlying health issue. My first client was about to be evicted because he hadn't paid his rent, but he was paying for his HIV medication and couldn't afford both. Or we had a mother who came in, her daughter has asthma and wakes up every morning in an apartment filled with cockroaches. And I grew frustrated, feeling that we were intervening so far downstream in the lives of these families. And in June 1995, read an article about Dr. Barry Zuckerman, then chair of pediatrics of Boston Medical Center. With Barry's blessing, I spent 6 months talking to doctors and nurses and heard the same story again and again. They said every day we have patients that come into the clinic and the patient has an asthma exacerbation, we prescribe a controller medication, but we know that the real issue is that she's living with 12 other people in a mold-infested apartment, and we don't ask about those issues because there's nothing we can do. We have 13 minutes with each patient, patients are piling up in the clinic waiting room, and I have nowhere to turn for help. Now, it seems that it shouldn't be so complicated to design a doctor's visit around what patients actually need to be healthy. But I've had hundreds of conversations with physicians across the country who say that when it comes to their patients' basic resource needs, they practice a don't ask, don't tell policy. Health Leads was born of those conversations and the conviction that there had to be a better way to leverage the assets of our healthcare system to do right by patients and by the providers who care for them. So fast forward 20 years, what's changed? It's now well acknowledged that just 10% of health outcomes are attributable to medical care, and the remaining 70% are attributable to social and environmental factors and the behaviors so influenced by them. We've also proved that it's actually possible to do something about these social needs with real results. With our healthcare institution partners, Health Leads has created 30 of these proof points, clinics that have swept aside don't ask, don't tell, and instead armed their physicians and other healthcare providers with prescriptions for food, heat, and other basic resources that they need to be healthy. We equip healthcare institutions with tools, screenings, analytics, workflows, a customizable technology platform to mobilize community health workers, care managers, and even college student advocates to work side by side with patients to access the existing landscape of community resources. And these connections work. A recent study at Mass General Hospital found that addressing patient social needs, in that case through Health Leads, yields clinically significant improvements in blood pressure and cholesterol levels, the former at a level that would satisfy the FDA threshold for a new drug. We found that when you address patient social needs, 69% of those patients are more likely to recommend their clinic, which makes perfect sense, right? That folks are happier when they encounter a healthcare system rather than a sick care system. But here is the part that troubles me. Notwithstanding all of that momentum, there is not yet still a single healthcare institution in this country that has made screening patients for and navigating them to community resources a standard of care. Not a single one. And I think we have to look that disconnect in the eye. Why is it that we can be accountable for every detail of our patients' clinical comorbidities, but when it comes to their social comorbidities, we're willing to settle with they're on Medicaid or they're poor? What does that even mean? How is it that the SVP of quality at a major integrated delivery system that collects thousands of pieces of data about its patients still says our patients' psychosocial needs are a black box to us? How is it that the challenge of keeping the lights on at our institutions has somehow become more all-consuming than the challenge of our patients keeping their lights or their heat or their electricity on at home? What we need, what we desperately need, what our patients need and what our sector needs is a paradigm shift. So in 1962, Thomas Kuhn, the physicist and philosopher of science, created this phrase, paradigm shift, which he defined as a revolutionary upheaval in the basic assumptions of the ruling theory. Kuhn explained that in every paradigm over time, enough anomalies and contradictions accumulate that the discipline goes into a crisis period, characterized, he said, by a willingness to try anything, the explicit expression of discontent, and debate over fundamentals. So I don't know about you, but that sounds exactly like the conversations that I am having with healthcare executives all across the country these days. Nobody exactly loves the current paradigm. And yet it's not clear what should replace it, and this is where you come in. Because the most compelling part of a paradigm shift is that it only requires the courage to see the world differently and to act accordingly. So to make this point, Kuhn showed this image. How many of you see a duck? And how many of you see a rabbit? Okay, I'm just gonna say I'm a rabbit gal myself. But it all depends, of course, on how you look at it, right? As Kuhn says, a paradigm shift is about handling the same bundle of data as before, but looking at them in new relation with one another because of a different framework. The question is, what will it take to shift the paradigm, to address social needs as a standard of care, and bring us closer to a more just and more rational healthcare system? I think it would mean embracing three imperatives. Imperative number one is to change the definitions. Our definition of what counts as healthcare in this country did not come down from the Mount with Moses. It is of our own construction, and we can choose to redefine it. So consider Carlos, who presents with multiple sclerosis, unmanaged diabetes, having missed multiple specialty visits and had many ER visits and hospitalizations. We have a lot of words for Carlos in our current lexicon, right? He's high maintenance, he's a frequent flyer, he's non-compliant, all of which assume his willful disregard for his doctor's care. But with health leads by his side, Carlos accesses a bilingual transportation company, secures vouchers for his medication, and navigates the mysteries of scheduling his follow-up appointments. And he makes his next 7 doctor's appointments. Now his doctor says, Carlos trusts us. This work does not have to be super complicated, but if it's done systematically, it is paradigm shifting. And in this new model of quality care, Carlos is no longer a problem patient, a worst case, a special case. He's just a guy with a few more comorbidities. In traditional healthcare, we define comorbidity as the simultaneous presence of 2 chronic diseases or conditions in a patient. But why? Why don't we consider a comorbidity the simultaneous presence of any 2 conditions that compromise the health of a patient? Why do we count diabetes and obesity, but not that a patient's running out of food at the end of the month? Can you imagine if NASA said that they were going to calculate the force required to get a rocket into space but not bring it back down to Earth? If they said, we're in the space exploration business, not the air travel business, so that last 50,000 feet that the astronauts travel between Earth's surface and Earth's atmosphere and the surface, that's not our problem. I mean, that would just be preposterous, right? But that's how we've structured healthcare today, where that last 50,000 feet, the actual difference between illness and health, is somehow somebody else's business. So if imperative number 1 is around language, number 2 is around action. Imperative number 2, change the work, address social needs as a standard of care. So last fall, I sat with Ray Baxter, an SVP at Kaiser Permanente, one of HealthLead's partner institutions, and Ray framed the dilemma this way. He said, at the one end of the spectrum, we could just pretend that these issues don't even exist in our patients' lives. Or on the other end of the spectrum, we could actually go build the affordable housing. And he said, we know that neither of those is exactly the right answer, but what is the role and responsibility of healthcare institutions with respect to patient social needs? Ray's question sweeps away this false choice between doing everything and doing nothing. And that's the whole nature of the paradigm shift. It's not about doing everything differently or nothing differently. It's about taking our existing assets and deploying them differently. The facts don't change, but how we see them and what we do with them does. So first, we have to break the cycle of don't ask, don't tell by expecting our providers will have the same rigorous understanding of patient social needs that they do of their clinical needs. We would never accept just a diagnosis of cancer. We want our physicians to tell us what type, what grade, what stage. Same with community resources. If those fancy new ICD-10 codes can require us to report when a patient was sucked into a jet engine, code V97.33, or better yet, pecked by a turkey, code W58.13, which I'm assuming is like a seasonal code, then surely we can screen patients for whether or not they're running out of food or whether their heat got turned off in February. The second is we have to act on what we learn. We have to navigate patients to community resources the same way we would to a specialist or a home health agency. The ultimate bad handoff, giving a patient an outdated list of food pantries and expecting her to navigate the language, transportation, and bureaucratic obstacles to her actually getting the food to feed her family that night. Number 3 is we have to build strong referral relationships with these community organizations. You wouldn't want to send a patient to a cardiologist you don't know. Same with community resources. And step 4 is to collect data about this work. It is still science. It is actually more precise science, holding ourselves accountable for the outcomes of health, not just the inputs of medicine. And data will tell you surprising things. So during one HealthLeads implementation, we in the clinic leadership assumed that the screen positive rate for unmet resource needs among the patients would mirror the clinic's Medicaid population, about 20%. So we were shocked when we found that 58% of the patients reported a significant unmet resource need. 58%. If you knew that 58% of your patients did not have food or housing, you'd probably want to include that information in your performance dashboards or your strategic planning, the same way you would clinical and financial information. So how do we go from healthcare to health tomorrow? And I think this is where Kuhn's wildlife becomes really helpful. If we look at all the assets of our healthcare system, our technology, our workforce, our infrastructure, and view it through the lens of health rather than disease, we unlock incredible potential, right? The rabbit becomes a duck. So how complicated would it be to write prescriptions, not just for what a patient needs to get healthy, but what they need to be healthy, like food and housing? To maintain a registry of patients who are food insecure, the same way we maintain a registry of patients with heart failure. Or to deploy our discharge planners, not just to schedule a follow-up visit with the PCP, but also with a job training program. Or use our financial counselors not just to enroll patients in Medicaid, but also in SNAP benefits. So many of the tools and resources to deliver health already exist, and you can enact the paradigm shift by seeing and using them differently and more fully. The third and last imperative is for us to be the leaders our patients are hoping we will be. So one of my heroes is Tom Lee, a physician at the Brigham and Women's Hospital and the CMO of Press Ganey. And I think Tom has scrutinized every square inch of the healthcare system, from quality to value, experience, and efficiency. But I still think his most profound insight is his simplest. Tom said to me, You know what all this healthcare strategy stuff is really about at the end of the day? It's about recognizing that every patient visit is a high-stakes interaction. It's a big deal for the patient, and it's a big deal for you. And all you have to do is be the physician your patients are hoping you will be. So what would it mean for us to be the healthcare leaders our patients are hoping we will be? I think it would mean looking the full picture of health, refusing to avert our eyes any longer from 70% of what impacts patient health. It would mean discarding don't ask, don't tell, and diagnosing Carlos with MS, diabetes, and insufficient transportation. To get there will require taking some risks and performing some courageous acts. But as Avedis Donabedian, who founded this whole study of quality in healthcare, said, it is exhilarating, even ennobling, to believe that the obstacles to good care can be circumvented or removed by ardently wishing it so. If you wish it so, if you act accordingly, you will join some pretty spectacular inside agitators who have already rejected the status quo and are working to architect the future. Leaders like Nirav Shah, the COO of Kaiser Permanente Southern California region, who says the surest path to the triple aim is through addressing our patients' basic resource needs. This is our work. It's not just our mission, it's a strategic business imperative. Leaders like Peggy Troy, the CEO of Children's Hospital Wisconsin, who used every patient visit in every clinical and non-clinical setting to screen for and provide her patients with immunizations, and has committed to do the same with respect to screening for and addressing their social needs. How do you convince a skeptical CFO of the importance of this work? Peggy's answer is simple. If you have to convince him, you probably need a new CFO. And leaders like Jack Geiger, who probably started the whole thing in the first place. In 1965, Dr. Geiger founded one of the first 2 community health centers in a desperately poor area of Mississippi. So many of his patients presented with malnutrition that he began writing prescriptions for food. And patients would take those prescriptions to the local supermarket, which would fill them and then charge the pharmacy budget of the clinic. And when the Office of Economic Opportunity in Washington, D.C., which was funding Geiger's clinic, found out, they were livid. And they sent down a bureaucrat to tell him that they had intended their dollars to be used for medical care. To which Geiger famously replied, the last time I checked my textbooks, the specific therapy for malnutrition was food. But here's the thing. In 1965, Dr. Geiger could not instigate a full-on paradigm shift because he was too busy, in his words, fending off the wolves, the rabidly racist physicians, state medical societies, and politicians who sought to end his work for good. He didn't have our privilege or our responsibility of leading in a time of unprecedented fluidity in the healthcare sector, in which the changes of health reform allow us to shed the old paradigm by changing the definitions, including what counts as healthcare, by changing the work, assuming responsibility for addressing patients' social needs, and by being the leaders our patients hope we will be, by refusing to do something as important as health with one arm behind our back. And the crazy part of it is, to get there, we don't need a single new innovation, invention, or insight. We just need to see things differently and act accordingly. It's not a rabbit, it's a duck, and that will make all the difference. Thank you.
Quality Talks is brought to you by our Underwriter and Go sponsors.
We cannot express enough how much we appreciate all the folks that have supported Quality Talks and sponsored this event and supported our work over the past 4 years in putting this event together. So I want to introduce to you our next guest. She is with ACAP, which is the Association for Community Affiliated Plans, and she's not just with them, she's the CEO. And ACAP is a sponsor of Quality Talks, and we show throughout this broadcast, a lot of logos of people who are participating in this. Why, Meg, do you all support Quality Talks?
Well, we are big supporters of NCQA and your mission to improve quality of care among health plans. Many of our health plans are accredited and more every day. We love working with you all to make sure that the accreditation standards are fair to health plans and raise the bar for everybody at the same time. So we think that it's an important organization to support, as well as the format is just fabulous, and I always learn something.
What do you think special about the format? What works for you?
What works for me is that it's just not death by PowerPoint, and people are talking and engaged. They're funny, they're moving, much more than you see at other types of conferences.
And you'll have to forgive me. I don't even know if I just said she was the CEO. I don't think I said your name.
Oh.
It's Meg Murray, CEO of ACAP. Tell me about the work you all do. You work with smaller plans, I think, for the most part.
Typically, although we have plans that range from 5,000 lives to well over 2 million lives.
Mm-hmm.
So our niche are the nonprofit plans that are focused on Medicaid. So at the smaller end, we've got here in D.C. The health plan for children with special health care needs, and Victor Fields is here from that. And at the other end, we've got CareSource and LA Care that I think each have over 2 million lives.
Oh wow, so that's pretty big.
So it's pretty
I kind
big,
of mischaracterized it.
Yeah, but there's a lot in the middle that are more mid-sized.
I think that community affiliated plans makes it, just because they're big doesn't mean they're not connected.
Right. In fact,
Correct?
almost all of our plans typically are in one state, or even like LA Care, only in one county. So they're embedded in the community, and they were formed typically by the community, by the children's hospitals, the county government, or other providers.
From a quality perspective, what do you think? The last year has been a busy one, I think.
It has been, and in some ways, while we came off the repeal and replace debate and successfully defended Medicaid, we weren't sure what was going to happen this year, but two really important things happened for quality this year in both two bills. I think it was the tax bill as well as the recent opioids bill. The law was changed now to require states to collect quality metrics in Medicaid. For children, and metrics related to behavioral health and substance abuse. So we think that that's really important because we believe in measuring, that you measure what matters. So now we're going to be able to know how the states are doing on those measures compared to each other and over time. And so we'll be able to know which states we need to learn from and which states potentially need more help.
On that opioid battle, there are so many directions from which to fight that, but there is a role for the health plans.
True. What we'd like to see, and what unfortunately was not in the opioids bill, is a change to the privacy rules. The privacy standards for substance abuse are much more onerous than the HIPAA standards. And so we think that the substance abuse privacy standards should move to the HIPAA standards, and the House agreed, the Senate did not. So that's our next battle, to make sure that, we want to make sure that people who are dealing with substance abuse are able to speak to the providers that are also on the physical health side, so that people aren't being prescribed opioids when they have an addiction, which we know often happens.
Enough business, let's go back to the fun. Toyin Ajayi, you told me before, that was your favorite
Yeah, she
so
was
far.
really fabulous, and not just because she she used to work for one of our members, Commonwealth Care Alliance. She was the CMO there, but it was just very moving in the importance of trust and building trust not only between providers and patients, but health plans and patients. And again, because our plans are embedded in the community and of the community, that's probably easier for us to make that case, but it's something we need to work on every day.
One last question. Tell the folks at home why they should be here in person.
It's great. There's good food.
Good food. There's more than good food.
Great.
Thank you, Matt,
Okay.
for joining us. Appreciate your time and appreciate the support again for Quality Talks.
Yeah, happy to do it. This is our third or fourth year, so.
Yeah, fantastic. Our guests here are now visiting the speaker hubs in the salon rooms here at the Reagan Building, and for the first time, we're going to bring that to you. This is a special and unique part of Quality Talk, so if you can make it in person next year, I highly advise it, and you'll get to see this and get the good food. It's an added bonus to dive in deeper with our influential speakers. Here's a peek in the speaker hub of Ezekiel Emanuel. You can see he is talking, and we'll just break right in now.
Own bed, much less likely to fall in the home because you know how to navigate it. It also means that house officers or doctors are not doing a lot of unnecessary tests all the time that add to costs. So I think that shift is clearly happening, and I think what you have to have there, look, the home care industry has been, one of the big problems is fraud, right? Hard to monitor what's actually happening there, are patients getting the services. I think we're going to have to do a way better job of that and standardizing that care so it's not on the fly. So some of the best places I've seen, whether it's with community health care workers, with palliative care services, et cetera, is they've actually standardized the care so that there's a checklist that everyone has to go through, and they have to actually prove that they've done it with the patient. And I think that there's a couple of chairs over here, please. That kind of standardization and validation of that is going to be really, really important for the industry. I mean, we have to, it's easier to monitor the hospital, right? It's all under one roof. They've got the data. Much harder in a distributed model where there's no one else verifying that you actually visited the patient, you did what you said, et cetera. The other thing I think we're going to have to do around home care is, now we have a lot of separate solutions, right? We've got the palliative care solution, visiting nurses, the physical therapists, right? Instead of 27 solutions to sending on a patient, right, we're going to need one platform where one person does it all or capable or coordinates it all, because otherwise you have to have a family member at the house constantly with the patient, and that's just not viable, I think. And so now I'm seeing, a uniform model where you've got one person who's doing all the care. But at the moment, it's still a lot of choreography. I talked to the people for CareMore. I don't know how many people know CareMore, based in LA, provides really top flight care for frail elderly in LA, and then they moved to places like Des Moines and Memphis, and with the Medicaid population, and much more difficult. And one of the things that they have told me about, going to a new locale and geography is the coordination needed to make sure you got the hospital bed when the patient's discharged, with the oxygen at home, with the VNA, all happening at the same time. Well, they built it up in LA area over 30, 40 years, and so they could work out all those kinks, but you drop down into a new city and you got to do that, and you're offering a service that you're taking risk on. Choreographing that is, we got to make it much easier. I think one of the things, now I'm just waxing a little too poetic, one of the things that, I hope no one's from DaVita here, the dreaded dialysis people did, is that they made ordering dialysis so easy, right? One order and they take care of everything else, right? It's very hard to now break that hold and move dialysis into the home out of the institution, actually try to prevent people from getting onto dialysis, do better, because they've made it so easy for a doctor to order dialysis. We have to make everything else so easy that's better for patients, sign a form and you can get dialysis at home as opposed to getting it in institution, that kind of stuff. But I believe that, home dialysis is coming. We're at, I don't know, Peggy, you'd know, what, 10, 15% in home dialysis, right? The rest of Europe is the rest of Europe. Europe is well over 40, 50%. We could be there, except that DaVita and Fresenius have, just made it so easy, and the other is not turnkey. And so we need to begin making these other things turnkey. I'd say the other thing, that gets me to the idea that it's not just hospital, but it's also going to be the offices, the independence at home experiment by Medicare for frail elderly, having the PCP go to the house. It's, again, it's had some teething problems and lots of problems, but it's generally saved a lot of money, better for these people. And I think a lot of organizations are just going to figure out, as I said, baby care. Prenatal care. It's like, first of all, you don't really need to see the OB, right? So you can send a nurse practitioner out. Similarly, baby care. Well, for 95% of babies, right? What is it? Height, weight, head circumference, and make sure they got their immunizations. I got a secret for you. You don't need 4 years of medical school and 3 years of pediatric residency to do that, right? I followed my dad around in the hospital, it's like not really that complicated. So I think that's also another thing. And bringing them into the office with all the viruses there, maybe not the greatest idea either. So you're going to see a lot more of these shifts, I think.
In the dialysis example that you put, you have to consider also that the physician behavior has a big influence of that.
I totally agree with you. It's the docs who write the order. I totally agree.
And then, it becomes a matter of money and dirty money that goes and flows from here to there.
Yeah. Look. We could go into the dirt. We don't. A couple of my colleagues just had an article in the New England Journal about the fact that, there are a lot of joint ventures out there between the dialysis companies and the nephrologists. We don't know. They're not public. We don't know the money flows, but I totally agree with you. I don't think the ethics would be on the up and up, we can say. I think they're probably quite suspicious. So we do have to change that. I totally agree with you, and we have to but we also, for the doctors who don't have a financial interest in the dialysis facility, but are referring the patients, we have to make it easy for them to refer to home dialysis. So, yeah. Tell us who you are so we...
Yeah, my name is Jack Sattler from Medtronic. So the division that I work for isn't typically what Medtronic is known for, the medical device. The division that I work for actually does remote patient monitoring. So we put a device in individuals' home that have multiple comorbidities, really high PMs, and actually monitor 23 different diseases, and actually will go at risk for a minimum of a 2-to-1 ROI on 5 of them. Heart failure, COPD, hypertension, diabetes, and CAD.
And what do you exactly measure and monitor?
So again, 23 different diseases, and so we capture biometrics data through either a scale, a blood pressure cuff, pulse ox, a glucometer. And so we take in that data, but then we also get symptoms data. So, for example, if somebody has got COPD, we'll ask if, you have more difficulty breathing today than yesterday. And if they say no, we move on to another question. But if they say yes, we continue to drill down to find exactly just how bad are they. And then their score goes up as they continue to say yes. So you had made a comment about how a lot of monitoring devices actually aren't showing that they're faring well. Well, I just wanted to state that at least this organization that I work for is willing to actually go at risk, because we do see, in fact, that we're able to reduce the PMs on those individuals that are monitored through our program.
And the peer review publication?
So the VA actually did a study.
I'd love you to send it to me.
Yeah.
Because, maybe I missed it, but we've done a fairly good job of keeping our eye out.
I'll get the information.
If it was in a general medicine journal, I'm sure I got it. If it was in a specialty journal, there's a good, especially if it's COPD, there's a good chance I didn't get it. But I'd love to see that, and I'd love to see what what exact physiological measures. I mean, the other problem is, and again, maybe there's another way you guys have solved this, is, if patients have to input the symptoms, if patients have to do something over and over again, getting them to do it consistently for years or months even, it has been a big challenge by most organizations.
Yeah.
All right, yeah.
Hi, Will Schrank from UPMC.
Hi. Nice to see you.
Nice to see you.
I'm sure Neil says hi. This is an inside joke, guys.
Well, your work in palliative care has been transformational, and it was really important to me as a fellow reading some of your great work. We
$20 after the session.
Deal. As a health plan, as other health plans here, we spend a lot of time thinking about measurement in palliative care. And we apply a bunch of different sort of administrative approaches to try to increase the amount of palliative care, whether it's prior auth before a third course of chemo. And we have a handful of measures, in particular in oncology care, that we're applying, none of which I think are great. They're all kind of soft. And I was wondering
Really?
Well, I mean,
like
we
what?
have... So it's hard. I think we have a couple about the frequency of palliative care in the last week or 2 weeks or month.
Yeah.
I would love to hear your thoughts about where we need to go in terms of quality measurement in palliative care, and how we can use those measures as ways to really reinforce transformational care?
So I am an oncologist. I don't know if that got said, but so I do think of the world through cancer, and so end-of-life care related to CHF or COPD I'm less experienced with. But I think in cancer, the easiest thing I would do, I mean, the big issue in cancer is the trigger, right? When are you going to open that conversation, and when are you going to measure or require the doc to confront that issue? So places that I've seen do it well rely on patients that go into the ECOG score. So ECOG is the Eastern Oncology Group, and they have a measure which all oncologists use of how physically limited is a patient. Now, you can go through 1,000 different, predictors, but for cancer patients, it's really simple. ECOG 0 is normal activity. ECOG 1 is, I've got limitations. ECOG 2, yes, I'm bedbound, but less than 50% of the day. ECOG 3 is I'm bedbound 50% or more of the day. Really straightforward predictor. And there's a group in southeastern Pennsylvania that uses this, and you have to, the oncologist has to, in the medical record, right, address, get the patient a pulse and get the patient a advanced care plan. And say, this is what we've seen, and here's what I think the change in course ought to be. Stopping with the chemo and focusing in on palliative care at that point, or if you're going to continue with chemo, it has to be an experimental phase 1, phase 2 trial. So in cancer, I mean, the irony is there's a whole series of diseases we know that, 6 months or less, or now a year less, if you've got lung cancer or metastatic melanoma, we're still not curing you. And so there's a whole series of diseases where if that's the opening diagnosis, and in lung cancer, it's, for more than 50% of the patients it is. And then this ECOG performance thing for the other patients. And then a requirement on the oncologist that they actually address these, they get the advanced care plan with the family and are required to discuss it. I think those turn out to be, that's the trigger. And then holding them accountable for, it's got to happen 85% plus of the time, if not, or giving them a bonus, however you guys want to do it. It seems to me that's the place. Now, obviously, once you've got that home care, you need to have a very good and effective care mechanism to provide palliative care at home. And, Aspire is a group that I've worked with. We're in the midst of trying to do validate their data. They've published some of it, but let's just say not quite at the academic standards that we would require, and they didn't do a randomized trial. We're trying to get them to do a randomized trial. But, that's a group that has provided palliative care. They claim a high percentage of savings, but they start much earlier than the last 3 weeks or month of life. I think the other thing I would, you guys could probably do is any patient with, again, where the prognosis and metastatic solid tumor is a good place, that gets it.
That's Ezekiel Emanuel giving his hub talk, following up on his talk on the stage. He opened up Quality Talks 2018 this morning. Welcome back. We're live at the Ronald Reagan building outside the theater. We're going to return to the talks pretty soon, but right now we have a very special guest joining us, my colleague, my friend, Michael Barr. He's the Vice President for NCQA's Quality Measurement and Research Group, and he's here to talk about another special event that actually is happening right here in this building.
That's right.
In just a few weeks. It is the Digital Quality Summit.
Right.
Right? Now tell me, who should come to the digital?
Everybody should come to the digital. No, anybody who's interested in quality measures, how we're moving from the current slate of measures to future slate of measures that rely upon digital information. Policymakers, technical people. The nice thing about this conference is it is really for all stakeholders who are involved, from the collection of information to the production of measures, and using those measures to improve quality of care.
What are you trying to accomplish with this summit? Because I know you guys have big ideas.
Big ideas mean we have to demonstrate them. So this is a really a practical way to show folks what we're trying to do, not just we NCQA, but what the industry is trying to do. So if you think about our current measurement enterprise, really is, for lack of a better term, stuck in the 20th century. We rely upon review of charts, we rely upon claims, which is still good data. What we're trying to do is move towards use of electronic information when it is generated and where it is generated at the point of care to develop quality metrics that use that information without requiring additional work on behalf of the clinical teams, clinicians, hospitals, networks, to assess quality and drive quality forward. So this Digital Quality Summit is about explaining the technical aspects, the policy aspects, looking at the challenges, and then as part of the conference, not just sitting listening to people talk about it, but actually create work groups that go off, do some of the work involved, and report back to the larger group.
You know, years ago, when the internet first sort of took off, they talked about ubiquitous internet, which means, you know, internet everywhere. Your refrigerator is connected to the net, right? And we all went, well, now not my refrigerator, but people do have their refrigerators connected to the internet. What you're trying to do is, I imagine, is the same thing. It's sort of ubiquitous measurement that it's measuring, but no extra work, no other, we're collecting data.
Right, I think one of the big issues is the burden of measurement, the burden of quality, the burden of reporting. And what we're trying to get away from is sort of eliminate that burden. Let's not ask clinical teams and their members to do more work than is necessary to actually provide the care to the people seeking care, right? And as a consequence of all the implementation of electronic health records and digital systems as part of the HITECH Act, we have those systems in place. Now, you could argue whether they have been maximized in the utility or the usability where it needs to be. Put that aside for the moment. There's a lot of information in those systems. It may be in the wrong places, it may not be complete. What we want to do is start adding value for the purposes of collecting that information, liberating it, making it available to use for measures. Start with what's available and then build measurement. And then as we improve care, we can see whether that information is being captured accurately or not. In this way, there's a motivation for those who are using those systems and those who are designing those systems to improve upon them. And as opposed to having too many measures, maybe we just don't have the right measures or the highest quality measures, but we could actually measure a lot more once that data become available.
I want to reassure folks that it is for everyone. So when he talks about this and he talks about the digital part of it, you don't have to be a digital wizard to attend this.
No.
In fact, they kind of would appreciate some non-wizards to attend because then they can give insight.
We want patients, families, we want skeptics, people who want to challenge this. Obviously, we want some technical people involved. We want policymakers to come listen. We have some very good keynote speakers. David Blumenthal is going to be there, Blackford Middleton, of course, our own Peggy O'Kane, Chuck Jaffe from HL7. I should mention this is in collaboration with HL7. The second year we're doing that with HL7. They're great partners. So there's Chris DiRienzo from Mission Health talking about the reality in the field as to how so many measures they have to collect and what the challenges are. So, and in between that are those workshops where people go off and do the work.
And I think that's the key, the unique thing. Yes, we have the speakers and they're interesting and they have great perspective, but you're going to get to give your own perspective if you come to this conference.
Absolutely.
We're going to a little bit of put you to work.
Yeah, don't come and expect to sit and listen. You listen a little bit, talk a lot.
Thank you, Michael Barr. It's November 14th and 15th right here in the Reagan Building. We hope you'll sign up, and the way to do that is to go to our website, ncqa.org, and search Digital Quality Summit. Thank you again, Michael,
Thank you,
for
Matt.
being here.
Appreciate it.
Well, now we have a quick visit to a special organization right here in Washington, too. We met Maria Gomez, the president and CEO of Mary Center, on the Quality Talk stage last year. We thought you'd like to see for yourself where she and her team work on the front lines of care. Mary Center strives to put the patient, the person, at the center of healthcare.
For us, the PCMH is really about the patient being at the center, surrounded with all these professionals and paraprofessionals that are really making sure that we're addressing all the issues that are about equity, right, and the disparities of healthcare.
I think that the elements of PCMH are spot on as far as, what healthcare should look like, and as we move towards the idea that we should be working with patients and making sure that they're healthy before they get sick instead of just treating their sicknesses, and being able to work with all the social determinants of health, as well as making sure that we're putting the patient's needs first, so like just availability and things like that.
Everyone is on the same page as to the goals of the patient. The patient is reminded often about what's important for them, that these things are all documented, that there is follow-through. Those all lead to better outcomes for the patient.
The physicians are learning so much about the patient to make sure that we're addressing all of the patient's needs as a whole. Little things like making sure that that patient has food on the table on a regular basis.
You just have a more holistic view of everything going on in the patient's life. Who has contacted the patient, who has put in goals for the patient besides you.
It translates to more consistent care for patients. It helps to organize us as an organization in general and just kind of feel more secure in the way that we're actually providing the care consistently.
Screenings are done in a more timely fashion. They're explained better. Patients are aware of what needs to happen in what time frame. And because this is all in writing in the chart, the results come faster.
It's a team of people that actually address all the kinds of needs that the patient needs, because sometimes the message has to be repeated 4 or 5 times, and by 4 or 5 different people and in 4 or 5 different ways.
Mary Center is always looking for ways to help patients maximize their health in every way possible. And with our patients, particularly those who are new to the country, those who may not speak English, navigating medicine and the medical world can be very difficult.
They do work from their heart. They like to try and take care of the patient.
When I arrived to the States in 1994, we became patients of Mary Center. When I say we, myself and my 7 siblings. Back then, because it was just my dad, we were in really need of support. Mary Center was there to help us out.
PCMH has, from an administrator's perspective, I see how well we went from literally not having any patients going to get their rectal exams to now, because of this process, to now I think we're up to 60% of our patients getting the exam. There is really no other way to really practice medicine in a way that is efficient, effective, and that we're working hard, but we know that we're working for an end that is actually making the patient better.
Putting the patient at the center of care is such an important part of the physician's job. Mary Center is really doing an excellent job at providing care. The center is also an NCQA recognized patient-centered medical home. We're proud of that. We're proud to watch their work in our own backyard. And I showed you that because we'll be talking a lot more about PCMH in our second segment after the speakers today. I am really excited to introduce our next speaker. She is Maria Scarlatos. You didn't think I would remember that name. I didn't even have to read it. And she's with Merck, one of our sponsors. Maria, tell me what you've seen so far today that you really like.
Yeah, well, this morning all focused on the whole patient, and I'm so glad that my segment comes right after that, because I'm so passionate about the way that we've been speaking about caring for a person and not a patient. As a pharmacist, you know, I'm taught in school and in life how a medicine interacts with the body, but we don't talk enough about how humans themselves interact with their own bodies and how humans interact with others and how our environment and the factors around us can really shape our health outside of checking certain boxes of healthcare. So it's been really inspiring to kind of hear about that this morning.
Well, and and it's hard when you plan these sort of events. We are trying to get the patient sort of perspective, but we're also talking about technology, and sometimes those two things come at a head. They're not mutually exclusive, but they're not the opposite either.
Yeah, I really like how the last speaker spoke about technology providing the information for us to then take it to the next level. It's really a partnership between data and technology enabling us to have human interaction in healthcare and use data to support quality improvement and healthcare improvement. I don't think they're at odds with each other. I think when we focus on just one part of the solution, we might be missing a piece, and folks are quick to point that out, and that's why they sometimes seem to clash. But certainly we need a partner, and just like different parts of the healthcare system need a partner to come together to care for patients and their communities and wherever they're at within the spectrum of healthcare, we kind of need to use all the tools in our toolbox.
I think Merck has supported Quality Talks as a sponsor since the very beginning. Yeah. Why do you all see that as important? I mean, obviously, I'll speak. Obviously, you get to connect with people you do business with here, but you all have a quality division. You work in that quality division, so it's important.
Yeah, absolutely. We have a cross-functional quality team at Merck where we really try to ingrain it in the fabric of all that we do, from inception of a molecule that may impact the human body to talking about it with healthcare providers and really understanding what the impact will be on the healthcare system. And as we move to a value-based healthcare system, quality is really, it's that vehicle by which we can understand what is valuable care, what should we be paying for, what should we be prioritizing. So at Merck, it's really important for us to ensure that we are not only relevant with those that are providing healthcare on the front lines, but that we're partnering with them to ensure that what we can provide is providing value. It's part of the greater plan to ensure that a patient reaches their goals. So thinking about patient-reported outcomes, thinking about the value that's provided to a patient should be incorporated in how we're thinking from beginning to end.
Tell folks who are watching at their office, that sort of thing, why it's good to be here in person. This is pretty good. This is pretty good, but there's more if you're here, right?
Yeah, there's a lot more. I mean, you kind of touched on it already. I feel like this is the World Series for quality. I work in quality every day, and I work with a lot of folks across the country, as well as a lot of them are focused here in D.C. So to be here in D.C. and have a lot of the players come together to talk about this topic that's important to all of us is awesome. It's great for networking. It's great for getting minds together and saying, okay, we just heard about this in the auditorium, but there's actual business going on back here in the hubs. I've actually seen exchange of ideas and exchange of, where can we partner moving forward? What can we actually do? So it's not just some place where you sit and you listen to the ideas, but you jump in and you work together. So it's unique in that sense.
Well, thank you very much, Maria Scarlatos.
Absolutely.
Did I say it right?
You did. Thank you so much.
Of Merck for joining us, and thank you again so much for the support from Merck for Quality Talks. Been here since the beginning, and of course they are sort of our top, I think it's gold level supporters. So we appreciate you being here.
Thank
and
you.
We appreciate your insight. Well, it is not always easy to trust those around you, let alone healthcare providers. Everyone has different needs to be met, and we all want to trust our healthcare providers. We want to know they have our back. Quality, you could say, fuels trust.
Webster's defines trust as the reliance on the integrity of a person or thing.
I trust that you listen to me and my concerns before you do anything.
I want to trust that you're keeping me healthy, not just treating me when I'm sick.
Trust is knowing that my medical tests are necessary, not a waste of my time and money.
I trust you when you don't scold me, but encourage me to take my meds.
I trust people who are welcoming, supporting, and caring.
You see, in our never-ending pursuit of healthcare quality, trust is everything.
We want to trust you as our doctor, But we want you also to send us to other doctors and hospitals and pieces of the system that are trustworthy. And so we're asking a lot of you.
I do love that video. We shot it for another organization's event that's centered on building trust. And of course, we heard Toyin and Ajayi talk this morning about trust, so it fit right in. But for the quality talks, we'll see you in about an hour for more of our coverage. Don't forget, the rest of our talk with Peggy O'Kane is still coming up. And for now, I think it's time to get back to the Quality Talk stage. I'm looking at our producer off stage. We will see you again after this round of Quality Talks.
Hello. Hello, Quality Talks. Welcome back. I hope you enjoyed lunch and our first hubs. We have a schedule change to tell you about, and that change itself is maybe instructive. Geeta Nayar, who was the speaker we had planned to bring you now, yesterday a family member developed a serious illness, and she was not able to resolve that situation in Florida in time to get here today. So, just as Peggy O'Kane's story earlier this morning about being a patient reminded us that eventually we are all patients, eventually many of us will also be caregivers, and that's what Dr. Nayar is dealing with right now. Let's move on, and this next speaker is someone who I've enjoyed meeting. He's a heck of a guy. What doesn't he do? Among other things, he runs a 70-acre organic farm and animal sanctuary. He's also the nation's leading expert on poisonous mushrooms, and in that role does more than 600 telemedicine consultations a year with poison control centers. He's also one of the most active and insightful thinkers about how information technology can improve healthcare. Please welcome John Halamka.
Thank you so much. And in fact, Andy, while you were introducing me, I actually just did a different kind of telemedicine consultation, and that is a dog in Connecticut ate a mushroom, and the veterinary folks want to know, what next? So, you see? Well, as he said, I've spent the last 30 years of my life working on the intersection between technology and medicine. And I hope today to argue that we actually don't have a technology problem any longer. We actually have the tech we need. What we have is a psychology problem, how we use that tech, how our hospitals and doctors adopt it. So I'm going to cover 5 different emerging technology areas, and I know it's right after lunch. Hopefully everyone's had some caffeine. And believe me, I'm not going to talk about standards or cryptography or anything boring. I will try to make this as personal as I can. So let's start with something you probably hear about all the time, big data. Now, what is big in 2018? I'm not even quite sure. I have 11 petabytes of patient-identified data just at Beth Israel Deaconess. And you may ask, well, what is a petabyte? I'll tell you this. So it turns out you walked into this hall about a kilosecond ago. Now, a petasecond ago, there was a brontosaurus in this hall. That tells you what a peta is. It's a really big number. I got 11 of those. Now, why is that interesting? In December of 2011, my wife, who's Korean, was diagnosed with stage 3A breast cancer. She's fine today. That breast cancer was estrogen positive, progesterone positive, HER2 negative. Now, I'm sure you've all read the New England Journal religiously over the course of your careers, and how many clinical trials have been done on 50-year-old Korean women with stage 3A breast cancer with those biomarkers? The answer, of course, would be none. But over the course of 30 years at Harvard, have we seen a few patients just like her? The answer is actually we've seen hundreds. And if I have 11 petabytes of patient data, and I can use algorithms to say, I have a patient in front of me today. What can I learn about all the patients of the past that will inform patient care in the future? So we actually did that exercise for her, and what did we find? Although there's not been a lot of clinical trials on this, it turns out Asian women are exquisitely sensitive to Taxol. Taxol turns out to cause neuropathy, right? Numbness of hands and feet. My wife's an artist. So you can imagine if the outcome for her was total cure, but numb hands and no ability to create, that would not be a patient-centric outcome. So what we said is we want cure, but we also want function. So we did a clinical trial of 1. And we took her Taxol dose in half, with the agreement that if there was an issue where she had a recurrence, of course, we would look at alternatives. But at the end of chemotherapy, radiation, and surgery, she achieved complete remission and total use of her hands. All of that is a function of looking at the data of patient experience before her. And I think as we go forward, not over the next 5 to 10 years, but over the next 18 months, you'll see this explosion of the use of data in this fashion to help deliver more personalized, more precise care. And this is going to sound a little edgy, but where do I store that 11 petabytes of data? Amazon. Now, why? Wait a minute, privacy, security. Well, I'll ask you this question. How many security engineers does Amazon have? 5,000. How many do I have? 5. Right? So moving our data to secure hosting in the cloud with Amazon is actually a risk mitigation. And I tell you that because then the tools to do machine learning or artificial intelligence on that data in the cloud much, much easier than trying to bring those tools inside a hospital data center. Another quick example on machine learning. So it turns out you're a young, healthy person, thin. You have, however, an inflamed appendix. And you need your appendectomy today. How much time in the OR should we give you? Well, everybody gets an hour. But wait a minute. There are 1 million people like you in my database, and every one of them who's been young, healthy, with no comorbidities has had 25 minutes. So we can actually give you the right resource that you need to get the job done with quality and efficiency, appropriate setting of care, appropriate amount of medical expense. Again, we're already doing this. So I have about a dozen machine learning and artificial intelligence projects running at Beth Israel Deaconess today against that 11 petabytes of data that's really tailoring the care that is appropriate to the patient in front of us. So that's big data. Well, what about the Internet of Things? Now, again, you hear about this all the time. More and more of us are buying devices for our home. Now, it's a challenge, however. Now, is anyone wearing a Fitbit? Fitbits in the audience? Okay. It's a lovely device, but have you ever looked at your heart rate on a Fitbit? So it turns out you're running, maybe you're a little sweaty, your heart rate's 20. Now, do I call an ambulance? I don't know. So this Internet of Things, I mean, a huge promise to deliver us more patient-centric care, but fraught slightly with peril because we don't quite know when to believe the data and not. So if it's an implanted Medtronic pacemaker and it says your heart rate's 20, yes, I'm calling an ambulance, but if you're running with Fitbit, maybe I don't. But let me tell you why I think this is such an important revolution. Use a personal example. And I should just warn you, so my wife and I have no privacy, right? It's okay. We've already signed consents with the compliance office. We have no privacy. It's good. About 6 months ago, I used a blood pressure cuff like the one you see here, and I measured my blood pressure. Well, I'm a vegan for 25 years, a body mass index of 21. I'm a farmer. My blood pressure was 170/100. Like, how could that be? I eat nothing but rocks and sticks. I mean, come on. And I was sure it was the cuff, clearly. Measured it again, 170/100. So my clinician said, being a CIO is very stressful. Cybersecurity, issues with doctors and nurses depending upon you. Maybe it's stress. Or if anyone's from Boston, Maybe it's that Mass Pike commute, right? Very, very bad. So he said, use your wired device to take a look at your blood pressure when you wake up, before and after your commute, before and after stressful meetings, maybe before and after too much green tea. And let's look and see, is there a correlation with a lifestyle issue? And it turns out there was none, right? So, of course, I needed a few blood tests, make sure I didn't have a kidney problem or other medical condition. And ultimately, my clinician decided I inherited my blood pressure from my father. Both my parents have had high blood pressure. And you can't choose your parents, right? So this is just something that happens to you as you age. So I was put on a beta blocker. Now, again, don't want to compromise anybody's privacy here, but if you've ever been on beta blockers, that's like negative espresso, right? I had 2 negative espressos, right? And what was the right dose for me? Well, wait a minute, you know, that's kind of not the way that electronic health records work. They say, you're a human, you get 50 milligrams, right? So I was put on a dose that sure controlled my blood pressure, but I didn't want to get out of bed in the morning. And so I was able to use this electronic device in my home, go from 50 to 25. Oh, it seemed to be okay. Go from 25 to 12.5. Oh, seemed to be okay. I did this in 3 days, not every 6 weeks going back to a clinician's office until we got it right. 3 days. So in effect, we use the Internet of Things to diagnose me and then to treat me and then to titer my medication to the right dose with few side effects without really my having to leave my home. Because all this goes from the blood pressure to my phone, from my phone to my clinician's office. And that is really how I see care being delivered in the future. We'll use those under $100 devices from Amazon to tailor care that's more personal and appropriate for us. Well, is this for everybody? My mother is approaching 80 years old. And I explained, very exciting, Apple and iOS 12.0 has HealthKit where she can download her XML formatted or Fire-enabled Argonaut standard medical record. And she said, huh? I said, well, what about this? What if you could go up to a device in your home and say, when do I take my meds next? Which color should I take next? When's my next appointment? Am I eating right? Whatever. She said, oh, I do that. And so we've started to, I give you this sort of disclaimer, Alexa, Siri, Google Home, not quite HIPAA ready yet. But by the end of the year, we should see Amazon signing business associate agreements on Alexa. By the end of the year, right? And so we've built 30 skills already for Alexa. We registered the term BIDMC with Amazon. So if the patient says, hey, Alexa, ask BIDMC something, then that comes to us and we answer. And we really think this is going to be pretty important. And on the inpatient wards, pretty straightforward, like when's lunch, when do I get my pain meds next, when am I going home? But imagine on the outpatient setting. I'd like an appointment with my cardiologist in 2 weeks, hopefully at the suburban location, right? And those are the sorts of things, especially for those who aren't very facile with these devices, we think are going to be empowering to patients. Something else that we're starting to use is beacon technology. These are $1. You put them on the wall. They've got a battery in them that lasts for a decade. And not only do we know who you are, but we know where you are. And therefore, we can set a context of the question and the answer that you might ask. Or do things like when a doctor walks into the OR, shut off their texting, right? These are the sorts of things that geolocation will empower. Cloud and blockchain. Now, you hear this term blockchain quite often. Be a little careful with it, right? This is not Bitcoin. We're not going to put Bitcoin dispensers in the lobby. That's not what we're talking about. What is the use case? So blockchain is a public ledger. It's something that anyone can read, and it is trustworthy. It's not operated by government or any corporation. So let me give you the example of what we're doing in South Africa. This is a Gates Foundation funded project. 65 million people in South Africa, 16% have HIV. Our job was to figure out, can we deliver to the patient? What is their care plan? What are their viral load numbers over the last several visits? And give them a medical wallet that they can carry around on not an iPhone 10, but a flip phone, something very simple. Problem is, South Africa has not very reliable infrastructure, bandwidth very expensive, so we were able to create a very decentralized system to store and deliver this data to patients. We also wanted to make sure the patients trusted the data. Because does everyone trust government? Does everyone trust Google or Facebook? I don't know. But this idea that you could put it in a public ledger that guaranteed the data integrity and trustworthiness was appealing. So we used the blockchain not to actually store the data, just to make sure that it wasn't altered, to make sure it was trustworthy, delivering it to the patients and helping them coordinate their care. We also solved another interesting problem. You know that if your name's John Halamka, it's relatively straightforward to match me across different sites of care. There are only 13 Halamkas in the US. But imagine your name is Maria Garcia, and you live in California. You just can't really match across name, gender, date of birth so well. So what we did in South Africa is we used iris scans or retinal scans to match the data to the person. So as they walk into a right-to-care clinic, we simply say, I'll scan that eye, and I'll pull up all the data we've associated with that eye in the past and ensure your care is coordinated and personalized, avoiding redundant and unnecessary testing. So I'll say, I think the future is very bright. These technologies I've outlined for you today, everything from machine learning and ambient listening and the idea of being able to use trustworthy computing, will give us care that I would argue is most likely going to be in your home and on your phone, rather than in traditional hospitals or areas of delivery. And last example to show you, imagine you have congestive heart failure. You've had 3 big glasses of soda and a bunch of Doritos, and all that sodium load, all that fluid starting to overload your body. You start to develop shortness of breath. So our app, BIDMZ at Home, asks you about your care plan, asks you how you've complied, and then takes the data from the devices in your home and says, you've gained 7 pounds of water weight in the last 36 hours. This is probably a congestive heart failure exacerbation in the making. So then we can intervene in your home, sending a visiting nurse, double your diuretics, and help with some dietary education. This is happening today. So as I said, not a technology problem, just a psychiatry problem. And I hope that as a society, these are the sorts of things we embrace, and patient-centric care is not 5 years away, but 18 months. Thanks very much. Have a great day.
Our next speaker is the first venture capitalist to speak at Quality Talks. She has a knack for pairing people who have big ideas with business leaders who can bring those ideas to life. Her roots are in Silicon Valley, but her views on technology are not what you might think. Here to tell us what smart money thinks about smart healthcare, please welcome Lisa Suennen.
Hello, everybody. I got to be the venture capitalist here, so I wore green color of money just for you. Great to be here today. This is such a wonderful event. So thank you to Peggy and everybody at NCQA for making it possible. I wanted to talk about all the changes that are happening in healthcare today. We see lots of changes going on around us, and when we really like them, we call them disruptive innovation. And when we don't like them, we call them disruption. And sometimes we make a lot of changes, and a lot of changes are happening, and all we're really doing is just moving deck chairs around on the Titanic. And of course, we all know that that is a fairly futile exercise because the Titanic's gonna sink anyway. I'm not gonna sing for you, thank God for you, but if I could have played my music here, I would have played Landslide, that line where they say, I've been afraid of changing because I built my life around you. And for many of us, the changes underway are very disruptive to our lives and to our careers and what we're used to. And for others, the changes that are going on in healthcare are a huge improvement. So let's dive a little bit into some of those changes that we're seeing. Now, how many of you guys remember Calvin and Hobbes, that old cartoon? Okay, thank you for being old enough to remember that. My favorite cartoon strip from Calvin and Hobbes is the one where he invents a magical transmogrifier. And the transmogrifier is basically a big cardboard box where you can use it to turn into anything you want. Well, it seems to me that after many decades of kind of ignoring each other and trying to build fences around instead of bridges across, the various stakeholders in healthcare, not so much the patients, but everybody else, are walking into the transmogrifier with great speed and without fear. And while I often am out there whining that nothing really ever changes in healthcare, it simply isn't true if you back up and look at the big picture. There's major transmogrifying going on. And the companies that are around healthcare and the organizations that are around healthcare are doing a lot to redefine who they are and what they offer to the market. It used to be if that you were a healthcare provider, you provided healthcare services, end of story. If you're a payer and insurer, you provided insurance. If you were a retail pharmacy, you sold retail drugs and other stuff like Band-Aids. And if you're a medical device company, you're out there with your widgets. If you're a drug company, your drugs. And if you're a tech company, you're building whatever the next gadget is for the kids who know how to use them, much as John just said. The prevailing attitude at that time was, this is my handy-dandy, business model and the way I do things, back off. Thank you very much, everybody else. But today, if you look around you, it's pretty clear that the rules have entirely faded away. It looks like some magician waved his magic wand over all of the healthcare industry and turned everyone from women to tigers, presto changeo. And just like Siegfried and Roy would have done it. It's so weird and also so logical in some ways to see what's going on around us. The whole thing really reminds me of these old-time children's flip books. You know those? Who remembers those? Oh, please God, a bigger number. Okay, good. And those books where you change a piece of the page and you can match a rhino's back end with a platypus's front end and make a whole new animal out of it, right? Well, let me take you on a bit of a flip book tour. Be mindful that you can't match back halves to back halves, and there's no promise of reproductive viability here. So for starters, health systems who have become somewhat fed up with pharma companies charging them lots of money have started turning themselves into drug companies. Yes, actually that's true. A group of 300 hospital systems led by Intermountain Healthcare formed a company called Civica. Have you guys heard about Civica? It's a generic drug company where they'll be manufacturing and selling generic drugs to the hospital industry, bypassing the drug companies, bypassing the PBMs, so they believe charge them too much. And while hospitals have been doing compounding for many, many years, they've never done something like this. This is a really new development. And at the same time, tech companies, most of whom we would never have suspected gave a damn about healthcare, are turning themselves into healthcare companies faster than Amazon Prime delivers. So for instance, Amazon has decided to become some sort of drug distribution company. We don't know the details. But this further amplifies the ability to bypass the traditional pharmacy benefit managers. And, oh, by the way, Amazon, a tech company, is also a major supplier of medical devices, both under their own private label and through other distribution deals that they do. In case you think this is an original idea, it's not. Alibaba, which is even a much bigger company than Amazon in China, has been doing the same stuff for years. They've got a major pharmaceutical distribution business, and they're actively building a health insurance product. So this is not a US phenomenon only, this is a worldwide phenomenon. And not to be outdone in the tech world, Apple acquired Bedit, and you may have heard about their watch. That's a sleep tracking company, by the way. You may have heard about the watch they've got that does all sorts of healthcare things. And they've also become a bit of a quasi-contract research organization with ResearchKit. And on top of that, they acquired a company called Glimpse, which helps you track your medical records from all your different EMRs, in theory anyway. Alphabet, who we talked about a little bit earlier with Vivian, acquired Synosis, which is a sensor company that helps you get biometric information. Alphabet also spun out Verily, where Vivian works. It's just an entire healthcare company, right? So 5 years ago, you never would have expected the Googles and Apples of the world to be going to the FDA for product approvals. Google stuck its toe in the health insurance waters too. They bought a 10% interest in an insurance company that's kind of a nouveau model called Oscar. And they're collaborating in some way, I don't know what it is exactly, to build a data infrastructure to, make healthcare great again or something like that. And I imagine, but seriously, Oscar is kind of interesting. It's leveraging technology for everything from scheduling to customer service to predictive analytics. And I can only imagine a world where you could integrate their Google GPS into this, so when you, one of their covered members, orders a pizza, it sends an electric shock through your phone to help bring your A1C down. You may be surprised to hear that Facebook is working and collaborating with NYU to improve medical imaging reading, particularly with MRI. They've collected 3 million images, the livers and the liver and the kidneys and the brain, and they're looking for ways to leverage their advanced AI group because apparently the voting business is not working out so well. Some believe that the most forward-thinking company in the country is in healthcare is Comcast. How about that? They're building their own system for employee health. They're building provider networks, clinics, care management systems, the works. They've done a major collaboration with Independence Blue Cross out there in Pennsylvania to collaborate to bring healthcare content into 60 million homes. You may curse them for making you wait all day to watch Orange is the New Black, but they are busy disintermediating the healthcare elite, so cut them some slack. And here's a random one. We all know that retail has shown a great interest in healthcare, but Best Buy just acquired Great Call, a provider of healthcare technologies and services for seniors, for older Americans. So now you can go to Best Buy and you can get yourself a washing machine, and one of those damn iPhone recharging cords, and some healthcare monitoring on your way out the door. Back to our transmogrifying. Pharmaceutical companies are moving in the other direction. They're turning into software and services companies. While most of these companies never had a data scientist anywhere near their buildings, now they're hiring them in droves. And companies like Roche are actively acquiring companies like Flatiron and MySugar, software services companies that come with data systems that the pharma companies never really thought about before, and they're using it for all sorts of things. Sanofi is out there investing in blockchain, as you heard just talked about, and AI and virtual clinical trials. Otsuka's launched a drug that has an embedded sensor, and Novartis and Roche have launched major digital technology innovation sites around the world. Medical device companies are becoming service companies. We're really seeing a gamut of stuff on the transmagrifying front. Retail pharmacies are probably the biggest changers. CVS has announced, as you know, that it's actually merged with Aetna, and building, in addition to that, an in-home kidney dialysis device. CVS is building an in-home kidney dialysis device that they're going to take to the FDA, and they can deliver your home with Cheetos and diapers or whatever else you need. They're also becoming a health insurance offerer, of course, through their Aetna merger. But in response, Walmart, who's an interesting organization, has whispered its intent to purchase Humana. Whether that'll happen or not, who knows? But it's an incredibly interesting strategy, I think, this integration, because they're also healthcare providers, as we just discussed. So if you've got clinics and insurance together, in the case of Walmart, and you're controlling the front door of healthcare, in the case of CVS, Aetna, et cetera, the healthcare systems, the hospitals you negotiate with should be very, very nervous. Insurance companies are also becoming healthcare providers. Obviously, we talked about that with Aetna. But how about this? United Health Group has acquired 30,000 providers over the last few years who now work directly for them. They've acquired several hundred outpatient surgery centers doing over 1 million procedures a year. And they have the ability, they say, to serve 70% of the US population today as a provider. That's a stunning, number compared to what they used to be. Humana's hot on their heels, buying up practices in Texas and Florida. They also bought Kindred, a home healthcare company. So now if you control 2 of the front doors of healthcare, the home and the outpatient clinic, you're kind of talking Karl Marx style, controlling the means of production here. You control where people go to the hospital, or if they go to the hospital. And of course, providers are becoming insurers. There's hundreds of ACOs, and something like 52% of all health insurance products on the market are now provider-based insurance products. And for all we know, retail pharmacies could join up with investment bankers and with, internet retailers and create the scariest new monster of all, the whatever that is, which is scaring the hell out of most of people in healthcare right now. Probably for good reason, because usually whatever Amazon and Berkshire Hathaway do goes pretty well. So far, I've not seen any insurance companies turning into drug companies, but it is very early in the year. Still, there's time. Oh my God, I'm exhausted. That is a lot of transmogrifying, and here's my question. Is all of this good? Is this disruption changing things for the better? Or once again, are we just moving deck chairs around on the Titanic? It's really hard to say considering how early we are in this cycle. By the way, this guy is the producer of the movie Titanic in real life, and that is a genuine simulated Titanic deck chair, so there. And when you think about players like Walmart and Amazon that have consumers' complete trust, and Toyin talked about trust earlier, it's such an important part of the consumer experience, you can envision major improvements in customer experience, in value creation and data usage to create great products that patients really like. No one has the ability to move markets more than groups like Walmart and Amazon. They do it every day. And Walmart is the second largest employer in the nation after the federal government. So they have a real stake in the outcome of making healthcare better. And considering the number of people that flow through these organizations and who interact with them, you really have a great opportunity to integrate social determinants of health and other things that aren't normally standard in the healthcare system. I can see, at least in theory, why this vertical integration on a mass scale can be a good thing, and why it would have the advantage for patients in many cases. Groups like CVS, Walmart, and Amazon may end up with large outpatient networks and telemedicine wrapped in an insurance plan, directly accessing lower-cost pharmaceuticals and medical devices. There's potential for something really good here. But I can also see how savings would quickly transmogrify into added profits for these newly created entities. Just imagine this emerging cradle-to-grave strategy. The same company that delivers you into the world can sell you the junk food that gives you your diabetes. They can manufacture and sell you the insulin to treat it and do the surgery when your foot gives out later in life. They can provide the monitoring to know if you're complying with your medical regimen, which they also manage. And hopefully, as a result, you will live longer. But if not, conveniently, Walmart already sells the end of the story. So if all else fails, you can go home and watch Orange is the New Black, assuming the Comcast guy ever arrived, and think to yourself, what a world. Wow, this is a major disruption going on through healthcare. We have to get real, though. What worries me about this is monopolistic practices are well known to raise prices, not reduce them. We're already seeing this through hospital mega mergers that have been taking place for years. And it used to be if you're a player in healthcare and you figured out how to reduce costs, you reduce somebody else's profit, right? But now it's rapidly changing to a world where if you reduce costs, you're increasing your own profit. But you could share that with consumers, but that's no fun, is it? So I think that's the crux of the debate right there. Are we really doing something that makes a good difference? So I gave so many examples of what's happening, because you can see this massive convergence going on, and it's remarkable to think how much is changing in such a short time, really. And we have to think about what we want healthcare to look like before it's too late. This is Amir Rubin, some of you may know from One Medical, talked to me about how when he started in healthcare, the industry made up 10% of GDP, and it was unsustainable, and then it rose to 15 and 20%, and that was considered unsustainable. And now, people are still screaming it's unsustainable. And he's right, it's totally unsustainably low. It's gonna keep going up unless something changes. I mean, Newton was wrong, not everything that goes up has to come down. But if we aren't thoughtful, we're gonna go up to 50 plus. And if we're really gonna reduce costs and improve quality, we have to hope the metamorphoses we see are more like the caterpillar turning into the butterfly and not like the beetle turning into the worm, turning into the beetle, turning into the worm. And that's my worry. This could all turn out to be great, or it could turn out to be kind of a mess. So we need to not just hope, but expect, demand, and act to make sure that these changes lead to better outcomes for patients, better access, quality, cost, and better satisfaction for all players in the industry to perform well. We need to have an ongoing dialogue about what an integrated healthcare system really is, because this is well beyond what Kaiser ever imagined. And we need to maybe take solace in the words of Ziggy Marley, who said, change for the better and not for the worse. Let's stand together and not break our curse. Thank you so much for your time today. Take care.
Maybe we're looking in the wrong places or looking to the wrong professions for ways to improve healthcare. Maybe the keys to improvement won't come from math and science, but instead from the arts or from architecture. Our next speaker is an emergency physician who's convinced that doctors need to think like designers. Please welcome Ban Ku.
We fail to understand the importance of design in the products, services, and physical spaces in healthcare. I believe that good design is good for healthcare, and I'm going to share with you how thinking like a designer helped me to be creative at my job and saved me from burning out as a doctor. I was the first in my family to become a doctor. My mom and dad are immigrants from South Korea. They never completed college. We were poor growing up. We were not anything like those wealthy families in that awesome movie, Crazy Rich Asians. Like many immigrants who moved here, or who are at least trying to move here, they saw America as a land of opportunities, and their dream was for me to become a doctor. But there was just one problem. I didn't enjoy my science classes, and math, I hated. It was my worst subject. I really suck at math, and yes, I am an Asian male, but no, we are all not good at calculus. I was always drawn to the arts and humanities. Much to my parents' horror, I chose to major in classical studies in college. Translating the ancient poets from Greek and Latin, that captured my imagination. Organic chemistry didn't. After surviving medical training, in spite of my math incompetence, I worked, and I still do, in an emergency room. And in the hospital, we use a secret language. A phrase that you will hear often in the emergency room is moving the meat. It's kind of terrible, isn't it? It refers to being efficient to diagnose and discharge patients as quickly as possible. And I am guilty of using this derogatory slang when trying to clear out a waiting room overflowing with patients when there are 6-hour waits. Working in the meat grinder that is the ER is hard. And I have suffered burnout. My symptoms are emotional, spiritual, physical exhaustion, feeling dehumanized, lacking empathy. Burnout among physicians, it's an epidemic in America. Everyone suffers with burnout, especially our patients, because burned out doctors will deliver burned out care. How do we address this problem of burnout? I've heard a lot of strategies, everything from practicing yoga to mindfulness classes, but the problem's complex. There are no easy solutions. There's not a magic antidote. Doctors can't yoga themselves out of burnout and into wellness. And in the case of my own burnout, my treatment plan consisted of tapping into creativity. That creative part of my soul that was trapped during years of rote memorization in medical school and the dehumanizing culture of residency training. Experts agree that doctors should have an outlet, a creative outlet, and to take up an activity like painting, or I've even heard swing dancing, but trust me, you don't want to see me dance. It's not pretty. I believe that creativity is the most underappreciated skill set in the healthcare workforce. And why do doctors need to search for creativity outside of medicine? Can't we bring creativity into the delivery of the healthcare system? And I believe that creativity, that making people healthier is actually a creative pursuit. So how can we do this? We can do this by embracing design. Design plays an important role in our everyday lives. We appreciate good design from the your most comfortable shoes, from the feeling of those to the experience of going into your favorite cafe. And we complain when products and services are designed poorly. When the iPhone 4 came out, there was a big controversy. It was called Antennagate. If you held it in your left hand, it started dropping calls, and people went berserk about that. They said, how could Apple design a phone with a flawed antenna? But why don't we talk about design in healthcare? Is it because our experience of healthcare is so bad and that good design in healthcare is so rare? Think about your last healthcare experience as a patient. Maybe you were perched on a high examination table talking to your doctor who barely made eye contact because he's typing away at his computer. That happened to me on my last visit. Or maybe you had to put on one of those embarrassing patient gowns with that opening in the back that totally exposes your butt. Or you had to take an entire afternoon off of work for a 1 p.m. doctor's appointment because you knew that doctor was not going to show up at 1 p.m. And who here has had the experience of a doctor's office or hospital asking you to fax in a medical form? It's 2018. Who even owns a fax machine? The journalist Sarah Cliff calls the fax machine the cockroach of American medicine. Our healthcare system obviously needs to be redesigned. The same is true for our medical schools. Medical education hasn't been redesigned since 1910. They are designed to fail because they were designed to produce doctors for the 20th century. Think about your future doctors. They are sitting in a lecture hall like this. They are college freshmen. They are pre-med. They were literally born in the year 2000. They know nothing of the 1900s. That kind of makes you feel old, doesn't it? They will be the ones putting us on chemotherapy, removing our infected gallbladders, giving us blood pressure medication. To change the future of healthcare, we need to redesign how these doctors are going to be trained. I started the first program in a medical school that formally teaches design thinking. It's one of the largest and oldest medical schools in the country. So what exactly is design thinking? My favorite definition comes from my colleague, the author and designer, Ellen Lupton. She says design thinking is a set of creative tools that generates ideas and solutions that meet human needs. And the practice of design thinking uses physical prototypes, sketches, and storytelling to help teams build empathy and actively engage with the situation. Ellen says that design thinking is an open mindset that invites people to rewrite the rules of business as usual. And design thinking isn't just for designers. Anyone can take part. Teaching design thinking to medical students and doctors and applying it to healthcare helped me to develop more empathy for patients and led me to reimagine my role as a physician. And I want to share with you 3 principles of health design thinking: prototyping, storytelling, and co-creation. Prototyping is the ability to communicate the ideas in your head in a physical form. When a team was looking to improve the experience of central venous catheter insertion, they use everyday objects like Legos, Play-Doh, and cardboard to prototype a redesigned medical package for that catheter to make it easier for a doctor to find what she's looking for during this procedure. And when we took on the challenge of improving sepsis care, we sketched and mocked up a prototype of an interactive checklist that might help doctors and nurses remember to perform the critical actions in sepsis management. Simple prototypes like this can lead to real solutions. And I believe that prototyping is a much better tool than those 1-hour-long meetings that we have at conference room tables for inspiring ideas. Storytelling is another method that we use. And part of our storytelling technique is what we call storyboarding. A storyboard explains an action with pictures. Storyboarding was extremely helpful to my medical students when they were designing a device to minimize sleep disruptions in hospitals. Storyboarding allowed them to validate their ideas even before they built a prototype. And this team went on to file for a device patent, form a company, and do a clinical study that showed that patients were able to sleep 20 more minutes per night while in the hospital. Co-creation, it's fundamental to design thinking. It means designing for and with the end user. Too often, we design solutions without the input of end users. If your team, for example, is trying to reduce hospital readmissions, try inviting end users, patients with congestive heart failure, and their caregivers. These end users can give fresh insight into problems. Our team is currently working on a health solution for the community of Kensington, Philadelphia. Kensington is at the center of the opioid crisis. The New York Times just came out with an article on Sunday about Kensington, and they called it the Walmart of heroin. It is the largest open-air drug trafficking for heroin on the East Coast. We went into that neighborhood and talked with residents and nonprofit organizations to understand their wants, needs, and desires. They told us that they were tired of being stigmatized by the heroin epidemic. They wanted to lead healthy lives. Not all of them wanted to get high. Together, we are launching a program where we are using food as a change agent. We hope to deliver low-cost, made-from-scratch meals that compete against fast food. We want to design healthy addictions. Anyone here can design for health, whether you are a healthcare executive, a nurse, a doctor, a patient, and a caregiver. Start by choosing a project that you feel passionate about. It might be redesigning your crummy waiting room or improving communication within your teams, or maybe it might be helping your mom who's aging to remember to take her medications on a daily basis. Co-create with end users, prototype a solution rapidly. I believe that we have the ability to use our imagination to make healthcare beautiful, and together we can redesign its future. Thank you.
Let's meet those speakers. We'll break now for another round of hubs. John Halamka, Lisa Suennen, and Bon Ku are making their way to the hubs. We encourage you to meet them there. Please do listen out for the chimes, which is your signal to come back for our final set of speakers. Enjoy the hubs.
And welcome back to the Quality Talks live stream broadcast. We're so happy you are here with us. We're going to get to the hubs soon as everyone gets settled in there. There are about 700 folks here, so it will get busy in this hallway, and then they'll all head to the hub. Time now, though, for another visit with Peggy O'Kane. We saw part one of her interview earlier. Here now, the second part of my interview with the president and founder of NCQA. There have been a lot, and I'll read them to you, a lot of good headlines lately. NCQA patient-centered medical homes cut growth in Medicare emergency department use. That's what we want to hear, right? NCQA patient-centered medical homes lower total cost for care for Medicare fee-for-service beneficiaries. NCQA patient-centered medical homes provide more effective care management and optimize use of healthcare services. Those are all things we want to hear. Those are recent headlines, and they're all things we want to hear, and really some of the things we've been saying, this is what's going to happen.
Right.
Are you encouraged by that?
I'm very encouraged by that. You know, I think we know, I mean, when we developed our standards, we didn't just sit in a room and dream them up. We went and looked at high-performing practices, and they told us what they did, and that translates into our standards. But, you know, people have been, I mean, appropriately skeptical. I think people need to be skeptical in this world. There's a lot of hype out there. So having the actual results come in, and, you know, I mean, nobody wants to be in the emergency room. People want to be healthy enough, taken care of enough that they don't have to go there. Hospitalizations, also no fun, you know, and we know that a more proactive plan of care, coordination by the primary care practice, these are the things, they're not magic, but they're not easy, and that's what the patient-centered medical homes do.
How do we encourage more participation in PCMH, although it's grown pretty well since 2008. But there are still some folks that just won't jump in. How do we get them to jump in?
Well, this is where we can't make that happen. It has to be payers, Medicaid programs, Medicare, states. Some states not in Medicaid. They can all do things. They can reward practices that go through the program. They can pay for it. New York State, for example. New York State has had a big push, and many of the PCPs, primary care practitioners in New York State, are already recognized medical homes. So now we're working on the second half of those practices, which is harder because these are more of the small practices, like up in the rural areas of the state, where primary care practices by definition are really busy, and so the great news is New York is paying us to do the reviews. They are paying third parties to do technical assistance to help the practices go through. And so there's a whole system of support to move this whole delivery system in New York State forward. And it's very exciting for us.
They've really committed to the concept.
They really
and to
have.
us. And let's talk about LTSS.
Long-term services and supports.
She passed the test. Long-term services and supports really is just a really long name to address care for the most vulnerable among us. The elderly, people who need, with chronic conditions that need constant care.
People with disabilities.
And disabilities.
Serious mental illness.
We've jumped into that arena. We talked a little bit about it last year. You happy where we are? Happy where we're going?
No, not happy.
Okay.
I'm happy that we're making progress.
Okay.
So it's thrilling that a number of states, we've developed long-term services and supports. Let me just say, these populations, there's really, healthcare can only do so much for these people, but they have practical needs. They, for example, physically handicapped people, they have mobility issues, right? And if you don't address their mobility, then they're going to be stuck in their home or stuck in wherever they're living, and they're going to be isolated, which is a huge threat to health. So a good system will actually take care, make sure that they have the right vehicles to get out, will make sure that their mobility needs are addressed. A good system will see if somebody's isolated all the time. And if there are family members that can be pulled in, many times family members are hanging back because they're not sure what to do. So the system now can look at this person and say, what is it that this person needs to be having a high quality of life? And that's more ambitious than, is their hemoglobin A1C under control? So it's a whole different way of looking at a person and asking the person about their goals and trying to make sure that the care system is supporting them in those goals. It's ambitious. We're thrilled that a number of states have now mandated that module, because the big thing that made us go into this is Medicaid is now putting these people into managed care. It used to be considered really kind of somehow shady to put them into managed care, but actually, if good managed care is really what they need a system that works around them as a person. And so we're there to help keep them honest and help the Medicaid program understand, are there people getting the right kind of care?
Make sure they're doing the things that they should be doing.
Absolutely.
Essentially.
So yeah, I feel good about that, but there's still a lot more to do.
There's always a lot more to
Yeah,
do.
there is. Yeah.
I mean, you're 30 years in almost on this, where you, it was a different time back then, a woman, and
it was a
bunch
sneak
of
attack.
employers.
It was a sneak attack.
You got them. Started, saying, hey, we need to really check quality.
Right.
And we need to do it broadly.
Right.
And you've come this far.
Mm-hmm.
I know you've shown some discouragement today about some things you think we have more work to do. And
I always am like that. I'm a glass half empty kind of person.
What do you know for sure about the future of healthcare quality? What will it look like 30 years from now?
It'll be much more customized to individuals. I mean, I think we're already talking about precision medicine, but we don't have a whole lot to show for that yet. But you know, they're really, the science is moving fast. And I think part of the challenge is to make sure the delivery system is able to deliver on what's currently possible scientifically. And that's kind of been one of the things that started the whole quality movement, was people understanding. We know that this, you know, blood pressure control will prevent strokes, it'll prevent heart attacks, it'll prevent all kinds of terrible things, and yet people's blood pressure is not under control. Why? What can the system do to make it better? And that's what this accountability has made people find ways to actually improve care and improve health.
Peggy, we know, and this is just a follow-up on this, we know that quality really isn't by the patient themselves. They tend to not check on quality.
Mm-hmm.
We wish they would more,
they
right?
They trust their doctor, and we don't want to erode their trust in their doctor, but behind the scenes we want to make sure that the system is providing the data to really feel reassured that everybody's getting the care they deserve. We're spending a lot of money on healthcare in this country, and we need to get the good results from it that are possible.
What is Peggy O'Kane's most dangerous idea?
My most dangerous idea is that in a future time, practitioners will be managing against the patient's outcomes, which are really not, they're going to be unique, and they're going to, I mean, in my dream, patient that's having cancer treatment will be asked, how are you feeling? And they will, you know, the system will respond much more to you as an individual, and the people will have the tools and the analytics to take action when the outcomes aren't what they're supposed to be. So we're still in an age when it's not very customized, when, you know, the doctor thinks that the procedure was a success, but the patient doesn't. Mm-hmm. So there are a lot of these things that if you really have the patient's outcomes driving the system and being the true north, that is going to revolutionize medicine.
So proud to be part of the organization that Peggy O'Kane has led for nearly 30 years now, and really she's led the healthcare quality movement. So thank you for that, Peggy. Now let's get a look at what's happening here at the Ronald Reagan Building. You can see there are a few folks behind me still out here in the hallway, but we're going to take you to a speaker hub. John Halamka is speaking right now to the attendees. Let's go there.
All these societies I'm visiting now that traditionally were quite fit and thin and now are eating KFC. And what ends up happening is they start to develop diabetes and have strokes and heart attacks and all these other things. You start to say, maybe there's something to be said for a largely plant-based diet. It's sustainable for the planet, it's appropriate for the animals, and yes, my wife and I are the founders of this animal sanctuary with 250 animals on it. So for me, that's worked. But here's been the interesting incentive issue. After I became a vegan and my medical bills went to zero, because they're pretty much zero, other than, yes, now I take 25 cents of a beta blocker every day. But again, I inherited that, not my fault. I went to my insurer, and at the time, Charlie Baker, the governor of the state of Massachusetts, was the CEO of Harvard Pilgrim Healthcare. And I said, Charlie, you know, I haven't had an accident in my car since I was, 16 years old, so I get a safe driving discount. I'm a vegan. Shouldn't I get a safe eating discount? And he said, no. We need people like you to fund all the smokers that are eating 18-ounce porterhouses every day. Thanks so much for your contribution. And so I agree with you. I'm starting to see health plans, and these are more your sort of alternative upstart kind of health plans, actually look at what is your lifestyle and reward you for lifestyle. It's the gym membership, it's the reward for eating right, and that sort of thing. So sure, might you actually build some infrastructure that allows you to track such a thing as proof that you have a reasonable lifestyle? I mean, interesting idea. But that's, I'd have to tell you, I'm not an irritating vegan, so I don't try to tell everybody, oh, it's like, oh my, this is how I live and you must too. I just tell my story because at least for me, it worked.
Are you aware of any cost-benefit studies that are out there showing,
Yeah.
$5 a week, it comes $20 off a month of their insurance, and they show collectively over time they're actually saving that company hundreds, maybe thousands of dollars every year because of that change in practice.
Well, I'm sure Neil Barnard has probably published on this, but I would tell you, our incentives are just not quite aligned. I mean, if you want to smoke, go ahead. It just costs you $5,000 more in premiums a year. Go ahead, it's up to you. We don't quite do that at this point. Now, you sort of wonder, will we move, as we are a value-based purchasing society, into individual responsibility? Could be. Other comments, questions, thoughts? Don't be shy. Yes?
With the Chronic Care Act coming out, do you have any thoughts about that and its relation to IT support and other things, just in terms of practice?
Yeah, so one of the interesting questions, if we look at Boston, right, where 80% today of our contracts are risk-based. They're already, way down the road of value-based. The IT that you need is totally different than you needed in fee-for-service medicine, right? So it used to be heads and beds were good, right? More capacity, and let's make sure we get more people moving through the system, whereas today, we would actually much rather keep you healthy in your home, because right care at right cost at the right time is far better. So what do? Now, I know this is going to sound awful, but there's very little I can do. How many different EHRs are there in just the Beth Israel Deaconess patient population? 26. And why, right? I can't control what the 2-doctor practice in the suburbs is running, right? We don't own the doctors, so fine. The hospitals I can standardize, but these smaller practices I can't. So about a decade ago, the state of Massachusetts started to build some quality databases for the community, and we leveraged that early experience. And today I have 26 EHRs all feeding their data on every encounter of every patient into one place. So this is a longitudinal view of every experience you've had, inpatient, outpatient, skilled nursing facility, ED, urgent care, or whatever. And clinicians, as you can probably guess from the last speaker, are utterly overwhelmed. So to ask a physician to say, oh, Mrs. Smith just showed up at an urgent care, can you examine if the care was right or wrong? It's a little hard. So we have care managers, which I'll call them care traffic controllers, right? And what they're doing is they're getting these 26 EHRs worth of data in a single database, and then we'll put rules on that as to when a care manager or care navigator should be engaged. And what they're doing is they're arranging things like visiting nurse services to the home, different kinds of support structures. Now, let me give you an example. Again, this may sound a little bit out there, but we really did this. We had a guy with COPD. Now, is anyone from New England? Okay, so August gets a little hot, a little sticky. Every August, this guy with COPD would show up in the emergency department. It was just so hot, he just couldn't breathe. And what was the cost of a COPD exacerbation hospitalization? $20,000. So we used this database. We sort of figured out this guy is coming in every August, look at his total medical expense. We went to Home Depot and bought him an air conditioner, right? $129, right? And he hasn't been back. He's still living, still doing okay, right? But hasn't been back in the emergency room in August because he's sitting next to his $129 air conditioner. And we did it because we're reimbursed in a value-based mechanism. It's cheaper to buy him an air conditioner than to see him in the emergency department. So that's how IT has to fundamentally change. Yes?
Question kind of on that same topic of value-based purchasing, I'm hearing a lot about co-creation here, which I love.
Yeah.
But also on the topic, and you mentioned it in your talk, about using patient satisfaction data to guide your wife's decision making. Right. And so, first of all, what are some ways that health plans and providers can begin to really use some of that patient satisfaction data in its current form, which is always, it's hard to use, But then also, how can we move forward with that to really build that co-creation using that patient input for even benefit design? And part of what drives my question is we're thinking a lot. I'm from the Alliance of Community Health Plans. We're thinking a lot about how can health plans use these new MA flexibilities for the things you just mentioned, the air conditioner, some of the things that really have a far greater impact on health. And the honest thing about that is that we are never going to know what those things are unless we ask patients.
Right.
And so what is that nexus between co-creation, patient reported outcomes and satisfaction data, and new payment models?
Sure. So let me tell you a little bit about our journey. So in 1999, early in my CIO career, a guy named Tom Del Banco came to me and said, you know, I can go to my ATM and get $20 at the touch of 3 buttons. Why is getting my full medical record electronically so hard? And I accepted the challenge. And then in 1999, we said, well, let's, in the spirit of co-creation and transparency, start giving the patients all their data. And immediately the reaction was, oh my God, you know, the patients are going to get lost and confused and anxious. They're going to call me at 3 in the morning. All these myths, right? So we started a little small. We allowed some clinicians to opt out and these sorts of things. Well, ultimately, after doing this for a couple of years and discovering more transparency and patient interaction is better, we made it a requirement of practice at Beth Israel Deaconess, and we share everything. Right? So we share it. It's not only your fully unredacted problem list and medication list, it's your psychiatric notes, right? Everything in the record is yours. And everyone said, well, that's good, but what if the patient has an opinion? What if the patient doesn't like what you wrote? What if they thought you misinterpreted the conversation? So then enter the My Notes project. And this is kind of interesting because what happens now, we deliver to the patient everything about
Underwriter and Go sponsors.
Welcome back to the hall here at the Ronald Reagan Building. I dipped out of that because the interesting thing you heard there, John Halamka was about to talk about My Notes and Open Notes. And we have another speaker today who will be speaking all about that, so stay tuned for that. We always love this Quality Talks opportunity to tell you about the things happening here at NCQA. Our patient-centered medical home recognition program continues to grow with more than 13,000 recognized primary care practices signed on to deliver care at NCQA's very high standards. Most importantly, they're all committed to continue to improve.
A patient-centered medical home is an opportunity for the parent to relieve some of her unbelievable duties of stress and anxiety that when she comes to her pediatrician, all of their needs are going to be met.
NCQA was the pathway to the medical home, and the patient-centered medical home was the last step in becoming a high-quality practice.
Our mission is to provide a predictably positive experience on every encounter and contact with our office.
Quality care is doing excellent care over and over and over again.
And again?
We would say, we do quality care, we do this, we do that. And NCQA would say, prove it. And I couldn't. I knew we did it, but I couldn't. And they offered that pathway through the patient-centered medical home process to be able to do quality care and to prove it.
To check health department site to see if there are any there.
The old way we used to do things was appointments however you do it in your office, 10, 15, 20 minutes. Go in, see the patient, do the exam, write the prescription, whatever.
At this age, you don't really get a choice of what classes you're doing, right?
Now we do something called clustered care, where we really are clustered as a team and we're taking care of the whole patient.
I got your message and I'll take care of it. And something about...
We now know exactly how many patients we have with depression, anxiety, ADHD, and we can really truly see where the demand is and what services are needed. we get to listen to the patients. We're not rushing to the next room or rushing to catch up.
Does he take anything for allergies on a regular basis?
We're getting to listen to their needs. We're getting to examine the patient more in-depthly to make sure that we're doing our job right.
Any pain in your legs, ankles, knees? No?
My advice to other practices is don't think about the investment in becoming a medical home. Think about the rewards that you're going to get once you achieve that level.
When I was really frustrated at one of the things that we were trying to do, and I can't even remember, one of the staff members at NCQA says, Dr. Abernathy, I understand your frustration, but remember this. You're about to join a very elite group of practices, and when we stick that seal of approval on your door, we want it to mean something, and it does.
That's an inspiring group of folks working there in Midlothian, Virginia. So now we move from the folks delivering patient-centered care to the special group of people guiding and advising them in their quality improvement future. Suzanne Madden is a true believer.
So the Burden Group was founded in 2007. I basically founded the company as a way to help level the playing
She's not
field
here,
for
so we got to
physicians
decide what
to understand that they were really working in a business environment, to also be able to educate them on the nature of healthcare delivery. Most physicians tend to look at themselves as being clinicians. We have often heard physicians lament and say, I just want to take care of patients. I don't want to deal with all of this other stuff, the insurance companies, the regulations, quality improvement, all of this sort of thing. So we basically wanted to set up a consulting firm that would really help and assist, in particular, independent practices. We do a lot of work in pediatrics and primary care, a number of other specialties as well, but we really saw the value of helping primary care practices be able to do things in a sort of a better, smarter, and more efficient way. So that was really the genesis of the Verdon Group. Since 2007, so we're in our 11th year now, we have approached our work from a number of different perspectives. In 2008, when NCQA launched their patient-centered medical home program, we were really excited to see that, actually, because we figured that this was a good process, if nothing else. It was a good process, a good framework for practices to really be able to engage in healthcare delivery in a way that was systematic, right? It can be very chaotic, particularly at primary care practices, whether it's pediatrics and you have 100 kids coming through your doors every day, or primary care where you're really dealing with a lot of care coordination, a lot of chronic diseases in adult populations. We really liked this model because we felt like this was a way to be able to get the team behind it and really sort of deploy healthcare in a way that was much more systematic. Obviously, over time, the PCMH program has developed and improved. We're excited about that too. 2008, frankly, was a bit more of a paper exercise, right? It was about sort of getting things down on paper and getting your policies and procedures together. By 2011, we were really seeing those processes morph into more of improvement, and how do you sort of create these good quality improvement programs, and can you get some traction there? By 2014, we were really seeing that the goal was to actually improve, not just attempt to improve, and so there were a lot more constructs built in that way to help practices achieve that. And now here we are, in 2018 with the 2017 standards in place, complete renovation of the program. QPAS is fantastic, right? We find that that's very user-friendly, really easy for practices to use, and that the program has evolved to the point now where we see behavioral health embedded into the patient-centered medical home, and we see some really great structures to just help these practices get better and better and better, as they go through these cycles. Often we talk about the clinical improvements. I'm an operational process person, right? So ops is sort of in my blood, process improvement is in my DNA. So to me, I actually find that some of the most valuable benefits for practices is really in how they're improving their processes, how they're actually able to deliver that care in ways that they weren't before, right? So I talked a little bit about the proactivity. Being able to walk into your practice every day and have a huddle with your team and know that you guys have a fundamental understanding of every patient that's coming in for the morning session, and that things are in place, ready to go, and nobody is worried about something falling through the cracks, really creates a very different atmosphere. We have actually used patient-centered medical home as part of the mission for some of the practices that we set up, right? It becomes part of the personality of the practice itself, right? So in other words, the culture of the practice that these employees are galvanized around. We find practices that may not have been terribly financially flush, let's say, you know, with cash. Some of them look to PCMH to say, well, will insurance companies pay me more? Can we actually sort of do better? Sometimes yes, sometimes no. Depends what area of the country you're in, depends on what payers you have. Frankly, some of the payers that used to pay for PCMH did it for a period of years, and now, you know, this has become a very mature program. They're sort of sunsetting some of these programs over time. But I look at that and I say to these physicians, listen, don't worry so much about the payers paying you money. Look at operationally what you save, right? If you're more efficient in terms of deploying your resources, you're saving some money there. If you have recall systems in place, you're bringing patients back in timely, you're bringing them in when they should, you actually have more visits, but in a more streamlined fashion, right? Most doctors say, don't give me more patients, don't give me more visits, where, you know, we're busting at the seams. And to that we look at and say, well, because most of that is same day haphazard stuff coming in, you can be much more operationally efficient and smooth out those bumps, and particularly seasonal bumps that we see, for example, in pediatrics, by having good recall systems. And so what we find over time is within a year of a practice transitioning into PCMH, they're much more financially solvent. They have much better processes. They're actually leaner and meaner in terms of how their resources are deployed, which is really, I think, a fundamental point, because most practices think that it's going to cost them more to implement patient-centered medical home. They say, oh my gosh, we're going to have to hire care coordinators and do all this sort of stuff. If you're a large organization, the answer is yes, because you're really going to put in different processes to manage things in different ways. But smaller practices are really just using the resources they have to do workflows in different ways than they were doing before. And what they're finding is it's much more efficient and people are much happier in their jobs because of it.
Madden helping us out with some discussion of PCMH, patient-centered medical home, and the program, and how she advises her clients about the benefits of that program. Joining me right now is my boss and the Vice President of Public Policy and External Relations here at NCQA. His name is Frank Michike. And Frank, this is all yours. This is Frank. Frank led this effort. Yeah. Tell me why, Frank, you think this is a good use of your people's efforts.
Sure. Well, I compare it to what I think of as sort of the conference circuit that I think almost all of us have been on at one point or another, where you're going to an event and you hear four often distinguished, brilliant panelists who sit on a stage together and go through 12 pages of PowerPoints, and I don't care who's talking. By the end of that presentation, your eyes are glazed and you're just staring at your watch or your laptop or whatever. And so this concept was to get at reversing that. That is the last thing we want. We want to give people inspirational, personalized, factual, of course, and inspiring, of course, but we want it to be quick and moving and just everything that reading off a PowerPoint slide is not. And we have been incredibly blessed with such a great group of speakers, with some of our own internal talent, whether that's Peggy or you or Andy as the MC. We've just been, you can produce the heck out of it, but if the speakers aren't great, if the folks who come in from NCQA aren't fully committed and passionate about what they're doing, it'll show. And like I say, we've been incredibly lucky to get the caliber of speakers we've gotten, to get their buy-in. I don't know, folks may not know, the speaker hubs is another way of being not your typical conference. Usually you go to one of those conferences and then everyone's standing in a line at the front of the stage trying to talk to one or the other panelists they wanted to talk to. And of course there's that guy in front of you who's for 10 minutes bending the speaker's ear with no sense that there's 10 people behind him. That's what these hubs are for too. But that takes a real commitment on behalf of the speakers to say, okay, yeah, not only am I going to go up there, I'm going to put together a inspiring presentation, but I'm going to come back after that. I'm going to stick around, which a lot of speakers, they do their thing and they hit the road. I'm going to stick around. I'm going to meet, commit to 25 minutes with the conference attendees. And then in a lot of cases, they stay for the whole day and a dinner at night. So it's been, there's just a spirit to this conference that I think is different than what a lot of those conference circuit events are like.
Well, one thing that Frank doesn't know that I want to tell him while we're here and sort of get his reaction. What he does every year, and what our leadership does, is push us to offer something new every year. It's got to get better every year. We are actually a quality improvement organization. And one thing we pushed for was to show you what the hubs look like. And we were a little concerned that that dip in may seem a little dry, a little too C-SPAN.
Yeah.
But
There's
it
no
turns
such
out
thing as
too much
C-SPAN.
C-SPAN
Yeah,
from the public policy
for
guy.
my
But
purposes.
it turned out very, very well.
That's
so
great.
That's something new. Something else we have that's new here this year is you can see it sort of right behind us, that booth with the light. It's a booth where folks can go in and give their own 2-minute quality talk. Now, you could do that at home, and we'll take it. Just send it to communications@ncqa.org. But we're going to use that and use it in our blog, videotape of folks giving their own quality talk. But also, it may turn out to be an audition. So that's new this year.
Crowdsourcing,
right?
Quality
it works.
improvement. Yeah.
But there's nothing like being here, though. Right?
Yeah, no, it's great. It is. I don't know. It's a special day, and so this is the 4th year, the 3rd year here at the Reagan Building, and you always worry that maybe it's becoming routine or whatever. It's something different every time. There's something new that inspires you, someone's story that inspires you. There's always a speaker who you may or may not have been familiar with who goes up there and just blows your mind and really changes the way you think about a given part of the healthcare system.
And on that note, we have 2 speakers coming up that promise to be pretty emotional, a nice heartfelt in. And on that note as well, we're going to take you now to a quality talk of the past and a guy who surprised us with how much folks talked about his talk and how much they enjoyed it. Let's listen to Dr. Joseph Torito from 2016.
Thank you. What a great day today's been. It's been really terrific for me sitting in the audience, and it's great to participate. So as you heard, I started my professional career as a pediatric ophthalmologist. I still practice today. And then I segued into this quality role where I help lead a physician group of about 1,300 physicians in their efforts to improve the quality they deliver, the care they deliver to patients in the Washington, D.C. area here at Kaiser Permanente. So my professional background has gotten me really used to people crying on a regular basis and not letting it affect me at work. Because what wasn't clear to me in this quality role is kind of being a grief counselor to a degree and taking people through the process of performance reporting. And so what I wanted to talk today about is my kind of process of performance reporting and how I take people through it. It doesn't work for everybody, it just happens to work for me. So really, the first thing that I'm always really clear with physicians and with nurses and healthcare providers is the difference between targets and goals. And your goal is what you desire your improvement to lead to. You know, improvement is defined as moving from the state of one being to a different state of being that's better. And so in order to do that, you actually have to measure, right? I mean, that is the NCQA, measuring quality. And that idea of measuring healthcare quality for a large segment of the healthcare industry is still foreign to them and still really scary. So we have to take them through the process. It's the only way for our industry to improve. So the difference between targets and goals, goal might be, you know, let's reduce hospital readmissions. And targets are really your interval places, maybe your process measures and your path to that goal. And it's really, really important when leading quality in a clinical space to always refer back to the goal. If you only talk about the targets, what's going to happen is people are going to coach to targets and perform to targets. And as soon as you reach them, they'll stop. So if you're trying to get to, let's say, breast cancer screening of a certain level, and you coach to the target, they'll stop once they reach that target. But if you're the woman who came after they met their target, the effort's not as great. That's not where we want to be. So you always have to talk about goals in the messaging. So taking that kind of in stride, what you have to do next is
define what you're going to work on, define what your measurement's going to be. And if, I'm very, very fortunate. I actually get to work in an environment where performance measurement is commonplace. I have a medical group that we actually embrace it. We weren't always that way, but every new measurement, every new thing that we're going to work on goes through the same process of socialization and then kind of the reaction that comes with it. It just doesn't become part of the routine every time you start something new. So the first thing that I always start with is whatever new thing we're working on, I always start, the first data point is how do we do as an organization? And how do we do, fortunately, hopefully there's a national benchmark. So how do we do compared to them or to the national benchmark? Using the same criteria, the same measurement methodology, as close as I can get it. And you just put that dot up and you let people absorb it and you let people kind of take it all in. And then you start segmenting that performance. And the next thing you do is say, okay, how do we do against that national benchmark by gender, by age? Sometimes we forget age, but by age, by ethnicity, by race, and now, even by product line. In other words, is it Medicare, Medicaid, Affordable Care Act, Marketplace, commercial? We can splice, we can dice, and we can compare to those national benchmarks. And when you do that and you release that, you're gonna get the interested few engaged, and they'll start asking you questions. You won't get the groundswell reaction, but you'll start to get some feedback, and that's good because, as everyone says, feedback is a gift. And so you start getting that feedback, and you start tweaking your message, you start tweaking your measurement, and then you have to make eventually that pivot where you start measuring by healthcare team or provider. And that's where you start getting into the scary space because it's a little bit threatening to people. And so what I first do is I send out that information kind of de-identified or blinded. So I just let everybody see it and take all that in and kind of say, and there's a protective mechanism. Most people don't assume that they're the worst. They just kind of figure somewhere in there. Someone introduced a concept to me a few weeks ago. I know I'm late to the game. This idea of illusory superiority, where we all think we're better than we probably are until the data tells us otherwise. And so let me kind of illustrate that for you. How many people in this room can sing? Show of hands. Okay. How many first graders, if I asked that question, would raise their hand? And so what's happened between first grade and today for you? Somehow, experience or the data has proven otherwise. Now, I would actually love for no, don't sing now, but I would love for all of you to feel you can sing. Because in moving quality improvement, you gotta make sure everybody at the end of this feels that they can sing. So, but we need to give them the feedback, the data, to tell them how actually you're doing. I know Laura talked about it earlier. Isn't it crazy we actually don't know how people are doing right next to us? So after you send out that de-identified information, the next phase, drum roll please, is identified, unblinded information. This is how you and your healthcare team is doing compared to your peers. And so that day that we make that pivot, I usually kind of do this. And, where's Dr. Trito? I think he left. We haven't seen him. Now, you have to be brave. You have to stand behind your measurement. You have to stand behind your data. And you have to then, what I call, walk people through the 5 stages of grief. And I'm not the first person to talk about this, obviously, in healthcare, but I just I see it over and over again. So the 5 stages of grief, what's the first reaction is denial. And I call that blame the data. The data's not right. Your data's, and then it becomes my data. Your data's not right. You sent me a list of 1,000 patients that you said I didn't do something. I found one that I did it. Your data's wrong. I'm throwing the whole thing out. It's done. which leads very quickly and sometimes simultaneously to number 2 reaction, which is anger. And I call that the reply all reaction. You, Dr. Trito, your data's not right, and I'm telling everybody. I'm telling everyone you sent this to, I'm telling your 2nd grade teacher, I'm telling your cousin in Minnesota, I'm telling everybody. And you actually have to react to that, because a lot of times they're right, your data isn't right. And so how can you lead performance improvement if you actually don't have good data? So you actually have to take that in. You have to go back and fix your report. Because if you don't, they're always going to throw away your information. But you also have to correct them if they're wrong. And you have to actually respond and say, yeah, actually, it was right. You kind of put that information someplace that nobody would find it, and you actually assumed that something was done when it wasn't in the medical record. So how am I supposed to read your mind? Politely. So, which then leads, after you get through that, and that can take a while, maybe a couple of rounds, you get to grief stage number 3. And grief stage number 3 is bargaining. And I call this phase blame the patient. My patients are sicker. Your patients aren't as sick as my patients are sicker, therefore I don't do as well on this metric. So I've been in clinical medicine almost 30 years. And the first day that I walked onto my first clinical rotation was the first day I heard from a colleague, yeah, my patients are sicker than yours. I've spent 30 years apparently attracting the healthiest and the most compliant patients ever. So, yeah, my patients are not as sick as yours, apparently, but let's compare your patients who you think are ever so sick to your colleagues who are ever so the same right down the hallway next to you. And usually you'll see variation. And I love demonstrating variation. My team will tell you that I live and breathe by variation reports because it debunks myth, because it breaks down that resistance to, I can't do this. Someone right down the hall is doing it with patients ever so similar to yours. Let's find out how they do it. And let's move forward. Because the natural next phase of grief 4 is depression. And depression you can really get stuck on depression. And I would tell you more for quality initiatives that have to do with outcome measures than process measures. Because outcome measures are really tough. They take a long time. And so I come from a medical family. Parents are both retired primary care physicians. Sister's another ophthalmologist. We were all having dinner not so long ago for a holiday or something. This whole idea of measuring clinical quality came up. And the talk from all but me was, I don't understand how doctors could be held accountable for people's hypertension control. And I said, do you all realize what I do for a living? I mean, have I not shared that I actually do this every day? We actually can make it, and then they got the lecture, we actually can make a difference in patients' hypertension control. Our organization actually changed our hypertension performance in a very short period of time, and we didn't get a whole bunch of new patients. We changed what we did. We put systems in place to actually do things. We highlighted success where it happened and brought people who were struggling to that level of success. And that's how you break out of that depression. But you can really get stuck in depression because the next phase after depression, joyfully, is acceptance. And that's where being a grief counselor in quality comes in. You have to walk people through this process to get to acceptance of, okay, how now do I make things better? And that's really where people start to do amazing things. And you actually, I say this, and I don't mean to be flippant, I have the greatest respect for healthcare providers, and I think one of the greatest parts of my job is actually help them do what they do at new levels and unleash their potential. So, I think you have to respect your audience and whenever you're doing performance reporting. So you get to acceptance of how do you get things better. And that whole 5 stages of grief, it can take years, it can take months, but I will tell you, just this past week, one of the members of my team actually had to speak to a grief-stricken physician who was dealing with a new performance report. He got off the phone, he said, "Hey, Dr. Torito, 21 minutes. I said, "What was 21 minutes? He said, "We went through the 5 stages of grief in 21 minutes. True story. I love that story. I have a whole team of grief counselors now. So how do you get people to a better place? And so the next phase is you actually have to help them. You actually have to give them a recipe. You have to give them the way and the means to do better. And sometimes the old way of quality improvement was just try harder. Just try harder. I'm a firm believer that that's nonsense. Just try harder. I think healthcare providers across the country are trying really, really hard. I think you have to model behavior, you have to show success, you have to put systems into place that support the right thing. I always tell everyone, make the right thing to do the easy thing to do, and you'll see great results. So the next thing that we have to do in this performance reporting that I think is our responsibility is the presentation of data so it's actionable. I think a lot of times people put up graphs up on a slide and you need, it's 6-point font and there are lines all over the place, and from a statistician point of view, it's a beautiful thing, but from a clinician point of view, it's malarkey. And you can't get everybody into the front row to see what you're talking about. So what I always tell my team is, it should be, and this is where I think my fine arts, visual arts background comes in. You can tell a story, picture's worth 1,000 words, it really comes true. Your report should stand on its own. You might not always be there to tell them the story, so your report should tell the story for you. That means clear data presentation, transparency about where the data is coming from, and a clear directionality of where they're headed. That seems really easy to do. It's not so easy. I took my team through a journey this summer where I actually made the request of them to standardize for every quality improvement effort in our whole portfolio, a standardized recipe, as I'll call them, for quality improvement. And I think that they can all testify, it was not easy. But they stand on their own. We give them, when people have a question, they know exactly where we are, where we want to be, and what's driving our performance, good and bad. So I think it's our responsibility to do the digging, connect the dots for people, but also to show them that there is a way to improved performance and help them be comfortable with the fact that clinical quality can be measured. As again, I would say, it can be the most rewarding thing in the world if you do it, but it can also lead you to have some battle bruises. But just think the great outcomes that it leads to for patients and for people under our care. Thank you.
Joseph Torito from 2016 Quality Talks, a physician and a quality watchdog at Kaiser.
Now, let's head back to the stage in this year's final round of Quality Talks speakers.
Welcome back. I have some news, and that is our hashtag QT 2018 is trending in DC. So thank you, Twitter users, for doing that for us. Now for our final set of speakers. Today, patients get the last word. Our next speaker is someone who, at an age when her peers were in school, she was traveling the country as the drummer in a punk rock band. When others her age were launching careers and starting families, she was confronting a life-threatening illness. The creativity and curiosity that she brought to that illness put her at the forefront of a social movement that makes patients partners in their own treatment. Please welcome Liz Salmi.
Okay, everybody, it is time to fess up. Raise your hand if you ever turned to the internet to research information about your own health. Yes, my kind of people. Well, congratulations, because you're engaged patients. Your internet search is not surprising. In fact, we know that out of the 40,000 Google searches happening every second, 2,000 of those searches are health-related. I am not a clinician, and I'm not an academic, but I am a patient. And so for the last 10 years, I've had a front row seat to the changing nature of patient access to information. Over the last 10 to 12 years, so much has changed about how we communicate with the world and with each other. Even how we talk about our health has changed. But what hasn't changed so much is how much information clinicians and health systems share with patients. So for the next few minutes, I'm going to share with you a bit about my life as a person living with a serious diagnosis and how I've come to embrace and advocate for more transparency and openness in healthcare. And then I want to shine a light on how increasing patient access to our medical records is going to be a game changer in improving quality and outcomes and safety in the patient's own care. But first, you need context. So here's my patient story. In 2005, at age 25, I picked Kaiser Permanente for my health plan for one really important reason. I liked their website. According to this website, I could pick a doctor, email that doctor, make appointments, and order prescription refills all online. And as a healthy young person, this was really important to me because it meant I did not need to talk to anyone. Fast forward to 3 years later. In July 2008, 1 week after my 29th birthday, I suffered a massive seizure. I landed in the ER, and scans showed I had a mass in my brain. And then, after a 9-hour surgery, I learned I have an astrocytoma, which is a slow-growing but malignant brain tumor, and it has a high rate of recurrence. 6 months later, that tumor grew back, and it sent me into a whirlwind of treatments over the next 2 years, including a second brain surgery, relearning how to walk and balance, and then 24 months of chemotherapy. There's no right way to respond to a cancer diagnosis. But my way was to first respond with fear, but then respond with curiosity. And because I have a digital communications background, my instinctual response was to start blogging about this experience and telling everybody, my family and friends, about what was going on with me. And for some reason, over the following weeks and then months, and now years, this blog gets an average of about 30,000 visits each year. Throughout treatment and beyond, Kaiser's online patient portal became a major part of my care. I loved this thing. After every appointment or test, I would faithfully log into that portal and stare at the lab results and metrics and graphs that were depicting various details about what was going on in my body. And if there was a word or a phrase I didn't know, well, I'd go online and look it up. And if I couldn't find what I was looking for, I would use that same portal to send an email to my doctor to ask a question. Because what use is this information without interpretation? So over the last few years, things have been going well with me. Spoiler alert, I am still alive. But early last year, something changed. In July 2017, my husband, Brett, was offered a great new job. But this new job did not give us a chance to stick with Kaiser for our health plan. We were scared and we were nervous, but I was also completely confident in my ability to transfer my medical records and pick a whole new care team. I had no idea that a simple request for my medical records was going to forever change the way I view having access to my health information. Now, you all know we have this legal right to request and receive and see a copy of our records. But I can tell you that this process takes time and effort, and sometimes costs are involved. Had I asked for a paper copy of my record, it would have cost 15 cents per page. Or in my case, $725.85. Of course, I went with a digital copy of my records on three DVDs for $45. But because I spent money on it, I was really curious. What did I just pay for? So I stuck one of those discs into the computer, and I found a 4,839-page PDF file that was my medical record for the previous 8 years of living with a brain tumor. What could be so large? So I pull up this giant PDF, took some time, and I started going through it page by page. And some of the things in that record I had seen before, such as emails back and forth with my doctor or those lab results. But the majority of it was stuff I had never seen before. Specifically things like this, my notes. Doctor's notes are the most important information in our medical records. They're there to remind our doctor and other members of the healthcare team about a patient's condition and plan for treatment. But like most people, I had never seen this information before. I could Google my condition, but I never knew what my own doctors were writing about me. And seeing these notes was eye-opening. It filled me in on gaps I missed when I was unconscious from surgeries and seizures. And they let me know that my doctors were really listening to me. They were quoting me. They were saying amazing things. And there isn't a single thing in my notes I don't understand or I can't figure out. And because I've been blogging this whole time, I'm now able to compare a blog post with my clinical notes. And for every question in this blog, there is a corresponding clarification in my notes. I can't believe it took 8 years for me to have seen this information. I don't want the next 29-year-old diagnosed with a brain tumor to have to wait 8 years to see her medical record. I don't want anyone to have to wait to see the information from their doctors in their notes. So, rhetorical question for all of you. How many of you find my response surprising? Okay. Well, I don't think you should, because I believe that patients like me are being created every day. And I'm going to break this down for you. You ready? In late 2006, the internet hit 1 billion users worldwide. Then in early 2007, Apple introduced this iPhone, and it quickly became one of the world's best media players, world's best phone, and world's best way to get to the web. And then a whole group of companies emerged or transformed in and around this year. And it quickly became one of the greatest leaps forward in history, infusing everyone with a new set of capabilities to collaborate, communicate, create, and gain access to information throughout every aspect of our lives. Why does that matter? Well, 1 year later, in 2008, I became a patient. My whole healthcare experience has been colored and shaped by this new culture of easy access to information. This desire for access to information is not coming from just sick people like me. This will continue to grow as people are living longer with chronic conditions, serious illness, or begin providing care for others. I think we should make it easier for people to have access to this information. 1 year ago, I started working with the Open Notes research team at Beth Israel Deaconess Medical Center. Open Notes is a movement backed by research that is encouraging doctors and other healthcare professionals to share the notes they write with the patients they're caring for. Open Notes is not software. Open Notes is not technology. It's about increasing trust and improving patient outcomes through transparency. And research shows that when doctors and patients are on the same page, looking at the same information, a patient's level of understanding increases. Open Notes research shows that when patients who have access to and read their notes, they feel more engaged in their care. They feel like they have a better understanding of their conditions, more in control of their health, and they take medications as prescribed. 99% of patients who read their notes feel the same or better about their doctor after reading as few as one note. And care partners benefit from reading notes as much or patients themselves. They believe reading the notes helps them have more productive discussions about those they are caring for. But what about doctors? Well, doctors who share their notes say that it has little to no change on their workflow, little change on the way they actually do their documentation. They believe that sharing notes increases patient satisfaction. And no doctors have reported ever ordering more tests or referrals as a result of sharing notes. But here's what you may care about most. When patients read notes, a significant number of us find mistakes. We find errors in our list of medications, our problem lists, and our medical history. And all of this has safety implications. This is huge. Patients can find errors. Think about it. Who better to find the error in the chart than the patient? My two eyes on my one chart versus my doctor's two eyes on 1,000 charts. In 2015, the National Academies of Medicine released recommendations about partnering with patients to improve diagnosis, and they specifically recommended providing access to notes in the EHR so patients can review those notes to look for errors. Healthcare leaders like you often talk about engaging patients in safety. But how do you set that in motion? How might we create systems for patients to recognize and report errors before they lead to diagnostic failures or other problems? Having patients review the notes could put into practice those recommendations from the national academies and create a tangible, scalable strategy. And Open Notes is the first part of that strategy. It is the first step to building strong partnerships between clinicians and patients. Today, over 150 health systems are now sharing notes with patients in all 50 states. They've taken that first step. There are over 31 million patients who now have access to their notes through existing secure online patient portals. And that sounds like a lot, but it's still less than 10% of the US population. Transparency. It's logical and it's ethical in healthcare. Transparency is logical because patients need information in order to be engaged in our care. And it's ethical because information essential to patients must be disclosed, and patients must be well informed in order to make decisions. And when it comes to our health, we're forced to make decisions. I love my doctors. I get great care. But it makes me wonder even more, why hide my notes? I think sharing should be the rule and not the exception. Our next internet search could be informed by our doctors, documented by our doctors, and shared in the form of an open note. We have the power to help ensure patient decisions are well informed. and that patients can be players in the safety of our own care. The tools are already here. We're already using them. Now let's just put doctors and patients on the same page. Thank you.
Almost 3 million Americans have served in Iraq and Afghanistan since 2001. Of those, 34,000 have been wounded. Of those, 5 have survived their wounds as quadruple amputees. One of them is here. His survival, recovery, and now advocacy combine several themes we've heard about today. The importance of both technology and community, of hardware and heart. It all comes together in his astonishing story. Please welcome your final Quality Talk speaker of the day, Travis Mills.
Thank you. Hey. How we doing? Hello, everybody. How we doing? Thank you. Oh, thank you. Appreciate it. Thanks, guys. Thank you. Oh, come on. We're good. I only got 15 minutes. We're good. Thanks, guys. Thank you. Thank you. Really. All right. I really appreciate that. That helps my nerves a little bit. When I walked out here, I got to be honest, I was pretty nervous. I hope I didn't, bomb this. Because last time what happened? Now, ladies and gentlemen, I'm excited to be here. I'm speaking on behalf of being a patient, but also about the technologies out there. So it's kind of the best of both worlds that I got to experience here in Maryland in Bethesda at Walter Reed. But we're going to get right to the story because I don't want to hold you guys up from any questions you might have afterwards and things like that. So on the screen, you were going to see my best friend, my wife, Kelsey, right? And she's awesome, and she's the best wife in the world. And the reason I know that, ladies and gentlemen, is because this is Staff Sergeant Travis Mills of the 82nd Airborne Division. We live in Fort Bragg, North Carolina. I jump out of airplanes, kick bad guys in the face. We have a house. Everything's going our way. And wouldn't you know it, she winds up telling me on a Sunday morning with excitement and fear that she's pregnant, right? 9 months go by, and my daughter's born. And the reason I know that my wife is the best in the world is because when I looked at my wife and I said, what do you want to name her? You think Madison or Avery? She looked at me and said, no, we have to name her Chloe Lynn, don't we? And I said, we don't have to do that. Why would you even think that? And she said, because, you idiot. You already got your ex-girlfriend's name tattooed on your arm. Yeah. Yeah. So, right? So we named her after my ex-girlfriend. It's not true. It's not true. No, my ex-girlfriend's the devil, but it's on. So everything's going my way. I'm coming up on my 3rd deployment, all right? I got to go over to Afghanistan for my 3rd time, and I had orders taking me somewhere else, and I canceled them because I have guys that believe in me, and they want to serve with me, and they come from all across this nation. So I went overseas. And the first day was a firefight, second day was a firefight, third was the same as the first two, very hot zone. We got a phone call about a month and a half in, April 10th. The phone rang, and the village elder was on the line. He said, hey, we got an IED in the village. We need you to come check it out. So we started putting our stuff on like normal. So as we're going over what we're going to do, we're strapping our gear on. We go out with the minesweeper, and we start sweeping the ground back and forth. Back and forth. Nothing alarms us there's anything there. I took my backpack off, and I set it on the ground. You see, my bag is 120 pounds, hits the ground, and underneath it is a bomb. And it takes my right arm, right leg automatically. When I'm on the ground, I think I'm going to die, so I tell the medic, don't worry about it, go save my guys. In my head, I'm just saying, don't freak out, stay calm. They rush me into surgery, right? We're going to fast forward into the surgery here. And they cut my left leg off because it's already gone. And then 2 days later, they have to cut my left arm off because the skin didn't necrotize, so I'm a quadruple amputee. On April 14th, they woke me up for the very first time in Launchville, Germany. And the first thing I said to my brother-in-law who was in the room, I said, my soldiers, how are my soldiers? And he told me about Brandon and Ryan. And then I said, am I paralyzed? And Josh looked at me and said, no, you're not paralyzed. I said, you don't got to lie to me because I can't put my fingers and toes. Tell me the truth. Am I paralyzed? He said, you're not paralyzed, but you don't have them anymore. And that's how I spent my 25th birthday, because that day was actually my 25th birthday. 3 days later, I arrived at Walter Reed in Bethesda, Maryland. My wife came up to me, right, and I saw her. And when I finally got the chance to talk to her, I said, Kelsey, you don't have to do this. Take the house, take the cars, take whatever money we have saved up and go. This is not the life I would choose for you. And she thought about it, and she said, I was thinking that. Yeah. Yeah. And then she came around and she said, you know what? Handicap parking sounds enticing. I'm gonna stay. But if you can imagine, she actually at 23 and I'm 25 and our daughter's 6 months old said, you know what? I'm gonna be here. We're gonna get through this together. So I'm at Walter Reed and I'm trying to recover. I had to find motivation, but I find motivation in my wife and my daughter. And all of a sudden, there's a brotherhood at Walter Reed. Because into my room, after I got out of a ketamine coma, which is this case study they did, where they gave me 600 milligrams an hour for 5 days straight, because my phantom limb pain was so bad, that when I was hallucinating, in and out of my hallucinations, a robot walked into my room. And the first thing out of this guy's mouth was, hey man, welcome to the club. I said, I don't want to be in your club. He said, kind of late now, don't you think? I said, oh, you got me there. And his name was Todd Nicely. And he showed me that with hard work and determination, I could walk again, drive again. He said, I'm the second ever quadruple amputee, you're the fourth. And two things went off. Number one, this guy showed me the way that I can get better. I can still be there for my family. And number two, he's a Marine. And if a Marine can do it with how dumb they are, I can easily, because I'm in the Army, I'm obviously brilliant. So the things I wanted to accomplish, I wanted to be able to feed myself again. I wanted to be able to pick a fork up and put food in my mouth. You see, I couldn't do that for 5 weeks. At 5 weeks, I was out of my recovery stage enough where I was healed up and I could grab a fork. I also was tired of sitting in a wheelchair. I thought, you know what, I want to be able to walk again. So 7 weeks and 4 days into my recovery, I took my very first steps at Walter Reed. It was very painful. It was not easy. And as I was walking around the track, they said, you'll walk 1 lap today. And I went ahead and walked 3 laps that day. And when I got done, I sat down, took a breather, and realized this could be something that I do. Now, if we fast forward a little bit, I wanted to be able to drive again as well. And let me tell you guys something. If you guys come to Augusta, Maine, where I live at, and you're on the road, and you see that white truck on the road, 6.7 liter turbo diesel, you know what I'm saying, got a tuner in it. They call it the compensator. I don't get that joke, but anyway. Do you guys see that on the road? Be very careful, because I'm an awful driver. The trick is, the license costs $430 in Maine for me. $30 I failed. But that guy could be bought. $400. That's right. Money buys everything, kids. Oh, you guys aren't in high school. Never mind. But the technology in that, right, in driving gave my independence back. And my wife and I at Walter Reed, we formed a really tight-knit bond with a lot of families there. Guys going through the same thing, and wives and children. And you know what? I realized it's all about giving back. So I'm going to talk to you guys a little about the technology and about what I have going on. But the first thing is, my wife and I now run a big nonprofit, the Travis Mills Foundation, where we take these veterans that have been through something like I have, combat or service-connected physical injury, and we show them how to do things like walk or drive, or not walk, or drive, no, I'm lying to you guys. We show them how to do things adaptively like kayak and canoe, and we bring out 8 families per week and let them know, hey, life goes on. We try to reinstill confidence in them and independence, because this is the lessons that I got taught at Walter Reed. This is the things that I was given the chance to learn at Walter Reed. Now, first thing we're going to talk about, click it for me, Craig. I got a guy in the back clicking my button for me. First thing I'm going to talk about is some healthcare technology, okay? The first thing that I got to know at Walter Reed was that I was going to be okay. So I'm going to tell you guys how my legs kind of work. When I started walking, I was very weak. I went from 250 pounds, right, 6'3", to like 3'6", something like that. Cut off at the knees. I know, it's crazy. And I had to regain everything. I went from 250 to 140 pounds. So when you look at the screen, on the left side, you're going to see my short legs. Those are the first ones you get. When you get taller, you get the ones on the right. The ones on the right, that's just gravity, okay? They don't do anything special, but when you trip, you just fall harder, right? The ones I'm wearing now are microprocessors. They have 4 distinct functions. The first thing is, they're little computers. Every time I move, internally, 300 adjustments get made to keep me as upright as possible. That's pretty exciting stuff when you're me. I also can slow myself down going down a jetway. They have hydraulic brakes with pistons. So when I get walking down a jetway, I don't go bowling for people. Yeah. Granted, Sometimes somebody will cut me off, and I'm like, oh, I can't stop. You know, yeah. No, it's too bad. And she's always like, oh, my hip. You know, I don't know why, but Ruth in her 80s is rude. Rude. They have Bluetooth connectivity, so I can lock my legs to 25-degree angle so I can drive my vehicle like everybody else. And the last thing is they're waterproof. So if I'm out in the rain and I get caught in a storm, I don't got to worry about my legs breaking and trying to find cover. They don't get broken in the water. Now the next thing, ladies and gentlemen, is my hand. And this thing's the coolest thing in the world. On the screen, you're going to see the most important hand that I own right there. It's not the one I'm wearing. No, that one. That one's called a greifer. That hand is in a Crown Royal bag on the top shelf of my closet. Yeah, and nobody touches that hand because that hand closes 25 pounds of pressure. And then when it's done, you can close it again, 35 pounds of pressure. And you see my daughter is 7 years old. Yeah, in 9 years, Johnny's gonna come knocking at the door. Yeah. And he's gonna be like, hey bro, like, did you just bro me, Johnny? That's 25 pounds of pressure. He's like, oh dude, that hurts. Johnny, there's no strike 2 and 3. This is 2 and 3 right here. Crunch. I break his hand. I know, sad. He's like, let me go, let me go. I pull Johnny close. I don't let him go. No. I say, Johnny, guess what? I don't know what. No fingerprints, Johnny. Remember that, Johnny. Now, that's the more technical side of my recovery process. And I have people signing up to come to my house for that day. So excited. There's also a brotherhood side. Now, through this experience, I was very upbeat. I had a couple life lessons I had to learn very quick. When I got blown up and I was down and out and I was wondering, why did this happen? I was embarrassed. I was angry. I was questioning, am I a bad person? Does God hate me? And the biggest question I honestly had, ladies and gentlemen, was why didn't I just die? Why did I live through this? And I found the answer in my family. And I found the answer in Todd Nicely, that corporal that came to see me that was retired from the Marine Corps, that told me I would be fine. So I decided I was going to talk to everybody I could that was at that hospital. And at Walter Reed, amputees are what you normally see. And me missing all 4 limbs, that was the worst you were going to see. So I'd go room to room. Now at first, the therapist and the doctor was like, hey Travis, you're pretty chipper. You're always happy. I got a guy I need you to meet. I can't tell you because of HIPAA what his name is, but I can tell you he's not in room 40, and he's not in 42. And I told you guys I'm not a dumb Marine, so I'm like, oh yeah, 41, duh. And the Marine's like, I don't get where you're going. Well, what? So I'd go up and I would say hi, and I'd say, hey, I'm Travis. You're going to be fine. Same message Todd gave me from that experience. Some people found out I did that. I became known as the mayor of Building 62, and they made a documentary on me. So if you guys have any patients or anybody you're talking to that need a little pick-me-up, that are wondering how they're going to get through their situation, go into Netflix, type in Travis Mills. I don't get paid per view, so I'm not like trying to have you guys give me a bunch of money. The next one I get paid for. So, but I'd love for you guys to be able to pass my message along because it's about resiliency and courage and making sure to understand what life really has to offer. Now, on top of that, I was also given the opportunity to write a book. The book's a New York Times bestseller, very proud of it. I made most of it up, so yeah. But the book's called Tough As They Come. Now, the story is going to tell itself, but the author's note's really the most important. The first thing it's going to tell you is if you did serve, thank you for your service. I didn't serve any more. I didn't fight any harder. I didn't do anything more heroic or brave. So I make fun of Marines just because I respect them. And the other 3 branches are like, whatever. But just joking. And the next thing it's going to tell you is I don't think my problems outweigh anybody else's. I am fortunate to live in a nation where I can wake up in the morning with no arms, no legs, strap my legs on, right, throw my arm on, walk downstairs. Well, it's not true. I have an elevator. But go in the elevator and go out and live life to the fullest. Take my wife and my daughter wherever we want to go. So if you guys want to check the book out, by all means, please do it. Go ahead and click it for me, Craig. Now, I normally talk for an hour, and I have a lot more to say, but the most important thing I want to tell you guys today is I appreciate the fact that you're here. I know that you're giving quality to everybody that you service, and if it wasn't for people like you, the medics on the ground that I had, the ability that I had to go to Walter Reed and learn how to walk and drive, feed myself, and get myself back up, I would not be standing here in front of you today. The 2 life lessons that I have learned that I want you to go and pass along to everybody that you meet, that you work with in the medical field, is number 1, don't dwell on the past. I learned that because when I was sitting in my hospital bed, closing my eyes and wishing that this did not happen, I realized you're not going to change the past. I can't change what happened yesterday, and I can't change what happened 6 years ago in Afghanistan. So I reminisce the 25 great years I had with legs and arms, and I've had 6 pretty great years without them. And the next thing I will tell you is you can't always control your situation. I learned that in my second deployment. We had just a day that was supposed to be 5 hours turned out awful, about 36 hours. You get to the point where you laugh or cry. And obviously I'm not going to cry. I'm a dude, and I'm like, look at But with that experience and so many more, and then the big explosion I had, I realized I can't always control my situation, but I can always control my attitude. So every day I wake up, my daughter comes into my room, wakes me up quietly. We don't make mom upset, because she likes to sleep and I'm scared of her. Because she's taking my arm off sometimes and she hits me with it when I'm in trouble. And she's like, stop hitting yourself, stop hitting yourself. Loopholes, you know what I'm saying? I also get locked. I used to be in the corner, take my arms and legs and put them in the corner, but I started getting out, so she puts me in the closet. No, I can't. It's not. But I will tell you that I've learned you can always control your attitude. If you have patients or doctors or physicians or anybody in this field that you work in that need to hear my story or want to know more about me, please visit travismills.org. At the end of this, if you guys want to ask questions and meet me out back, please do. Get pictures. I'm not contagious. You're not going to catch the arms and legs from me. I can guarantee that. About 98% sure. And I thank you for all that you do and having me here today. And as you guys can tell, if you guys have any questions, nothing's going to embarrass me. I'm going to throw it out there if you haven't noticed yet. Still got it. Still works. And there's my son, Dax, to prove it, named after the 2 medics. So, ladies and gentlemen, absolutely. So, I appreciate your time. I'm thankful for the technology out there. How my hand works is off muscle flexes, and I'll explain it more outside, but just know I'm able to grab whatever I need to grab, drink whatever I need to drink, feed myself, dress myself, and everything I need to get back to do with life because of all the things out there and advancements. Now, I've outran my time, and it's my honor and distinct privilege to introduce to you, or not introduce, but recognize and bring back on stage Madam President. If you would, please put your hands together for Madam President Peggy. Thank you.
Thank you so much.
Absolutely. Thank you. Thanks, guys.
So we've had amazing speakers here today, and I want to recognize Andy Reynolds and his staff that spent so much time planning this. I want to thank the wonderful speakers who I think today they've told us how far we have to go, how we're going to get there, and why we do it. So thank you all for being here. The reception is at 4:20. Meanwhile, we have the hubs. I'm sure, Lisa and Travis have a lot to teach us. So I hope you'll make time to go to the hubs and then celebrate a little bit with each other because we're all here because of healthcare quality, and that's about making patients better. So thank you for being here. Thank you.
That was Peggy O'Kane, of course, with leading NCQA, founder, nearly 30 years. And that was our final round of speakers here at Quality Talks 2018. It's been a full day. We hope you enjoyed it. We certainly did. You certainly can review all these talks on our website, qualitytalks.org, in the coming days. And we also hope you'll consider joining us in person here at the Reagan Building the next time. It's great to be here and to network with other professionals in the quality space. We'll be sending you all the details, so keep an eye out. For now, that's Quality Talks 2018. We'll see you again, no doubt.